And
or can you unshare now, because we'll be live? The webinar will be now be starting.
Mandar, unshare please.
Yeah. Siddharth, are we live?
Upon live केले sir.
Can you unshare now, because we'll be live? The webinar will be now be starting.
Yes, we have.
Mandar, unshare please.
Unshare झालं sir.
Okay. Siddharth, are we live?
Unshare केले sir मी.
Yes sir, we are live.
Okay, okay. So good evening, everyone. IMA Akola and Akola Orthopaedic Society cordially invites you for a very interesting webinar. Elbow is a very enigmatic joint. And today we have a galaxy of stars who are going to be talking on elbow injuries for us from the field of orthopedics. And me being an orthopedic surgeon, it's my privilege to hand over the whole dealings with Dr. Sanjay Shinde, who is an eminent orthopedic surgeon from our city. He is dealing with spine. His special interest is in spinal injuries, but he's also a very well-renowned trauma surgeon. So I hand over the dealings to our convener today, Dr. Sanjay Shinde. Sir.
Thank you, Tejas. Thank you, IMA Akola and AOS for endowing us with this responsibility of conducting this CME on elbow injuries today. So am I getting seen? My screen is getting seen?
Yes, sir. It's visible. Sir.
Yeah, yeah. So to begin with, like the very first moment when our IMA president, Akola, Dr. Mahendra Kalesan, asked me to conduct CME on elbows, the very first picture that floated in my mind was this, which we all have seen quite humorously, that a world leader who was refused to by his subordinate health executive to shake hands with him and was indeed offered with an elbow bump, which soon become quite a laughing stock. Poor guy was much smart enough in quickly adapting to the other one commonly used Indian gesture of folding the hands. Clearly, I'm not intending here to discuss the geopolitics in today's meet, but I'm using these images just to reiterate the importance of painless, mobile, and stable elbow in the overall functioning of the upper limb. Before diving deep into the pathologies, let me quickly take you through this one relevant anatomy video. Can you hear the voice from this video?
It's not very clear. It's not very clear, sir.
Okay.
Sanju, your voice is not coming very clear.
Okay, I'll check it, sir.
Effective use of our hand requires a stable, painless elbow joint. The important structures of the elbow can be divided into several categories. These include bones, joints, ligaments.
Siddharth.
Hello?
I'm stuck somewhere.
What happened?
My screen is stuck.
Do I stop?
Yeah, please. Is it clear now, sir? Tarun sir?
Voice is clear.
Yes, much clear, Sanju. Much clear.
Mandar, you stop sharing your screen.
सर माझं बंद आहे ना सर.
Sanjay sir, are you there? I mean, are we stuck
Yes,
with the
sir.
webinar? Or?
No, it's going on, I think.
So we cannot see your screen.
No?
Hello.
No, sir.
I had shared it already.
हा बरं.
दिसत नाही सर, स्क्रीन दिसत नाही.
Acha, sorry. I thought like it was running. Sorry. Now it is getting seen?
Yes, sir, we can see it now.
Okay, just give me a minute.
Sanju, we can see your screen.
Yes, sir.
But if you are speaking something, we can't hear.
Can you
Sanju,
hear the video sound, sir?
No. We can see the video, the slides which are being run, but we can't hear what you are saying.
No, I'm not saying anything right now. Just the video sound is happening.
Okay. Then it is running.
Okay. Sir. Tejas, commentary of the video is not getting heard.
No, sir, we cannot hear it. We can see the video, we cannot hear it.
Okay, some issue with that, I think, but I'm like the graphics are enough to understand
Yes,
what
sir,
they are
that is
talking
the
about.
difference. Yes, sir.
Yeah. So the author has described a relevant anatomy of the elbow, right from the bony articulations, then the ligaments and neurovascular structure. So elbow, we all know like gets affected with these various conditions like various syndromes, entrapment neuropathies. The elbow being surrounded with various bursas, tendons, and muscles, it is prone to develop myositis, tendonitis, bursitis. Various inflammatory and infective arthritis condition can affect the elbow. And then there are the injuries peculiar to the age group like pediatric, young adults, and the old age. They do behave in a different manner relevant to the strength of the elbow of that age. And they do get present in the form of pain, stiffness, instability, deformities, which are in turn outcome of the either malunions or the non-unions of the elbow injuries, and the contractures or the ankylosis, bony ankylosis or soft tissue contractures at the local elbow itself or in the regional manner affecting the forearm and the hand. So we are trying to cover most of these things in today's CME. I'm fortunate to have good eminent faculties with me who are going to contribute on this content. I'll get started with our very first speaker, who is a senior orthosurgeon from Akola, Dr. Tarun Rathi, sir. I'll invite him to talk on issues around the elbow.
Thank you, Sanjay.
Yeah, sir, you get started.
Sanjay, you will need to stop sharing so that I can share.
I stopped already. You share your screen now.
Yeah. Okay, good evening, everyone. Welcome to the CME on elbow. I have been asked to speak on aches or pains around the elbow. Myself, Dr. Tarun Rathi. I am practicing since last 23 years at Akola. I have studied from Mumbai University, and let's begin our topic today. So pains and aches around elbow can be classified in a way that pain on the lateral side of the elbow, pain on the anterior side of the elbow, pain on the medial side of elbow, as well as pain on the posterior side of the elbow. So we will begin with the most common condition which affects on the lateral side of the elbow, that is tennis elbow, which is also called as lateral epicondylitis. It's a non-specific inflammation at origin of the extensor muscles of the forearm.
Tarun sir,
Mainly,
sorry to interrupt you. Sir, your
Yeah.
screen is not, we cannot see your screen, sir.
you cannot see.
No, sir. Please share your screen.
Just a minute. I have already shared.
So stop sharing first and then reshare again.
Okay. You can't see anything? Tejas?
Not yet, sir.
Not yet, sir. Not yet, sir.
So how do I go back? Because I can
You
see the
You
screen.
exit from the slideshow mode first.
Oh,
Stop sharing and then reshare.
okay. You could hear my voice, but
Yes,
you
clearly.
could not see the screen.
Screen, yeah.
Okay,
Yes,
just
sir.
a minute. Hold on. Hey, Rajat. Rajat. स्क्रीन शेयरिंग किया बताओ वीडियो वहां जाने को नहीं मिल रहा मेरे को
तर ते टास्क बारच्या वर ग्रीन बटन आहे शेअर स्क्रीन ते दाबून बघा.
You haven't shared screen. Go to the Zoom. Okay.
Tejas, you are around?
Yeah.
Yes,
Tejas.
sir, I'm here.
Yeah,
Can you
so-
see the screen now?
Now it is started,
Yes.
sir. Tejas, just take care of the chat box, okay?
Sure, sir.
There are many inquiries happening. Just keep responding to them.
Sure, sure.
Go ahead, sir. Tarun, sir, you are seen now.
Yeah. Okay. All right. So, welcome to the CME. Sorry for this issue. I am going to talk on aches or pain around the elbow. So, the pain around the elbow, as I already said, can be pain on the lateral side of the elbow, pain on the anterior side of the elbow, pain on the medial side, as well as pain on the posterior side of the elbow. So let's begin with the most common pain on the lateral side of the elbow. The slideshow is not moving. Okay. The most common pain on the lateral side of the elbow is tennis elbow, lateral epicondylitis. It's a non-specific inflammation at origin of extensor muscles of the forearm. Extensor carpi radialis brevis is mainly affected. It presents with pain at lateral aspect of elbow in the area of lateral epicondyle. Usually the pain gets increased or aggravated by activity like lifting or pushing. So on examination, there is a tenderness which is localized on the lateral epicondyle of the humerus. Pain is aggravated by stretching of extensor muscles. The most common test which is done is Cosen's test, where you ask the patient to make a fist and then you ask him to dorsiflex the wrist against resistance. Patient will get severe pain at the lateral epicondyle area. You can also ask patient to do a wringing test. In both the condition, there is severe pain at the lateral epicondyle. X-rays are usually normal in this condition. Usually, patient is treated conservatively in the beginning with analgesics, anti-inflammatory drug, some elbow support is provided. Patient can also be asked to see a physiotherapist, which then gives him some local ultrasonic therapy, teaches him some stretching exercises. If this does not relieve his pain, local hydrocortisone injections can be given. 1 ml of triamcinolone can be given at the site of the injection. One of our very close friend orthopedic surgeon from Akola used to specifically talk about how to give injections in tennis elbow. Multiple pricks he used to advise for hydrocortisone injection. Some people also give platelet-rich plasma for this condition. If there is recurrence and recalcitrant cases, MRI can be done. Patient can be investigated with MRI. And if a fibrosis or a fibrotic area is seen around the lateral epicondyle, especially in the region of extensor carpi radialis brevis, arthroscopic release have also been done in this condition. Now, the pain on the medial side of the elbow, which is also called as golfer's elbow or medial epicondylitis. It is non-specific inflammation at the origin of flexor tendons of forearm at the medial epicondyle of humerus. It is also called as little leaguer's elbow, where throwing motion is used in the baseball by the leaguer. Pain usually is caused by the downward swing of the golf club, or people who swing a hammer every day at work, they also get this pain on the medial epicondyle. Treatment is also along the line of the tennis elbow, where you do icing of the area, analgesics, anti-inflammatory drugs are given. Then you can also give local ultrasonics as well as some stretching exercises for the patient can be given. To diagnose this condition, reverse Cosen test is done. The reverse Cosen test is like you ask the patient to make a wrist and flex it against resistance. Or if this does not, analgesics, anti-inflammatory, icing, if this does not relieve the pain of the patient, local hydrocortisone injection can be given. Next condition which is seen on the posterior side of the elbow is olecranon bursitis. Olecranon bursitis, where the pain and swelling is seen on the posterior aspect of the elbow on the olecranon. The causes are many. Repetitive friction can cause olecranon bursitis, which is also called as student's elbow. It is also seen in minors. It is also seen in draftsman. So it is also called as minor's elbow as well as draftsman elbow. It is olecranon bursitis is also seen with gout. It is also seen with rheumatoid arthritis, or infective condition. When patient presents.
चैट्स में वो लोग डाल रहे हैं, वो गलत है क्या?
Hello, Deepak, your mic is on, I think.
अच्छा.
Hello. So in infective condition, what we see is pain, swelling, redness in the region of the olecranon, and patient is to be investigated and treated as per the cause. In case of repetitive friction, if you avoid the causative factor like repetitive friction movement, then patient gets benefited. In the case of gout, patient is to be treated accordingly. For gout, rheumatoid arthritis is treated with anti-rheumatic agents, and in infective condition, you start the patient on antibiotic therapy. If it does not get relieved, then surgery is also done for excision of the bursa. This is a picture where it is shown the inflammation of the bursa, and the pus or fluid present in the bursa can be aspirated. Next condition, which is seen on the medial side of the elbow, is cubital tunnel syndrome. It is due to entrapment or compression of the ulnar nerve at the supracondylar process of humerus medially at the arcade of Struthers near the medial intermuscular septum between the two heads of origin of flexor carpi ulnaris. Here you see the ulnar nerve is passing. This is medial epicondyle, and it is passing through the cubital tunnel and between the two heads of the flexor carpi ulnaris. Usually the cause is repetitive flexion or some bony growth in the region of the medial epicondyle, which causes entrapment or compression of the ulnar nerve. Diagnosis is usually done by a positive percussion test. Then patient will, in a severe condition, patient will present with tingling numbness sensation on the little finger as well as the medial half of the ring finger. In a same like what we do for the carpal tunnel, a positive elbow flexion test can be done for this condition. On full flexion of the elbow, tingling numbness is seen or felt in little finger and the medial half of the ring finger in 1 minute. In some condition, EMG, NCV can also be done. So how do you treat this condition? Treatment is usually conservative, like avoiding flexion, or some splints can also be given, splints which prevent excessive flexion of the elbow. And in a very severe condition where you see wasting of the muscles and severe symptoms, decompression of the ulnar nerve can be done in this way, where you deroof the ulnar nerve and transpose it subcutaneously or submuscularly. Next condition is, which is seen on the radial side or the lateral side of the elbow, which also mimics like tennis elbow, is radial tunnel syndrome, where a cutting, piercing or stabbing pain is felt at upper forearm or back of hand on lateral aspect. Nerve is compressed or entrapped at arcade of Frost, as it is seen in the adjoining picture. Diagnosis is with percussion test. EMG, NCV can also be done. Treatment is initially conservative, and if patient is having severe symptoms, then decompression of nerve can also be done. Arthritis of elbow can also present as pain or ache in the region of the elbow. Causes can be arthritis, which happens post-injury, rheumatoid arthritis, gout can cause arthritis of the elbow, then psoriasis is known to cause arthritis of the elbow, lupus, or post-infective. Usually, patient presents with pain, swelling, and stiffness, restriction of the movement of the elbow. Crepitations can also be felt. Treatment is usually conservative, and if patient is disabled and in severe cases, replacement can be done for patient. Next condition is Osteochondritis Desiccants. This is seen in young patient, where a small piece of cartilage with bone gets dislodged in the joint. Patient usually presents with pain or swelling or tenderness and locking sensation. Investigation is X-ray and MRI of the joint, where you can see the piece of the bone along with cartilage is in the joint. Treatment is by surgical fixation or excision of the fragment if the fragment is small. On the anterior side of the elbow, you can get biceps tendon rupture. So biceps tendon, it inserts at radial tuberosity. Rupture of the biceps presents with pain, swelling, bruising, and at the anterior region of the elbow. In case of acute rupture, a Popeye sign can be seen. As there is loss of supination of the forearm due to biceps rupture, surgery is done where the biceps is again repaired and tied to the radial tuberosity. Ulnar coracoid ligament injury, which is seen on the medial side of the elbow, is again one condition which presents with pain around the elbow. It is also called as Tommy John injury. It is seen in pitchers of baseball. Patient usually presents with chronic pain and valgus instability of the elbow. Evaluation is done with MRI. Treatment is usually you stop throwing the baseball. Physical therapy can be given, and in sportsmen, if there is valgus instability, it may need reconstruction of the ulnar collateral ligament. Pain on the posterior side of elbow can also be caused by posterior impingement syndrome. It is also called as valgus extension overload injury. Athletes usually present with posterior elbow pain that worsens when elbow is extended with loss of velocity and control. Athletes may experience catching, locking, or stiffness of elbow. With repeated force extension of elbow, the tip of the olecranon is jammed in the olecranon fossa, causing inflammation, cartilage injury, loose fragment, and bony spurs. Treatment is usually conservative and rarely surgery is required. So these are the main conditions which cause pain in the region of the elbow. So thank you very much, Sanju.
Thank you, Saran.
Yeah.
Thank you, Tarun sir, for such a wonderfully summarized talk. Please unshare your screen now.
Okay, just a minute.
Stop sharing. Yeah. And I'll request all the panelists to unmute themselves for interaction. We'll quickly try and finish it up in 5 minutes time. And then we'll try and further stick to our time frames because we are running a little late. So all panelists can hear me?
Yes, sir.
Yeah. Tarun sir nicely summarized all the possible reasons for HS around the elbow. Let me dig into one of the commonest presentation on the lateral aspect of the elbow, that is tennis elbow, we all know. Quick spot diagnosis, what I'm indicating here. Can anyone tell me?
Local steroid injection.
Local steroid injection causing depigmentation of the skin.
Yes. So a local steroid this infiltration or there, if it gets leaked subcutaneously, most of the time we tend to get this kind of depigmentation, which is cosmetically little unappealing, and patients do complain about that. What is the status of steroid injections today, if I may ask? Though sir has said that steroid is the one routinely utilized measure, but what is the current status of its use? Is it recommended now? Considering this side effects associated with its use in the form of depigmentation, local fat atrophy, and tenocyte suppression, which actually doesn't help in the healing of the whatever the reparative process has to happen there. In the long run, these injections indeed are not helping us. They will give short-term pain relief, but in long run, they are little deterrent to the overall healing process. Do everyone agrees to it?
Sanjay sir, is it okay if I comment on your question?
Yes, please.
Yeah, so as an arthroscopic surgeon, I would say that for someone whose local steroids are still, in fact, in terms of the academic literature, there is still use of steroids in tennis elbow. However, a lot of your patients.
You're not audible, Tejas.
Sorry, sir.
You were not audible, Tejas.
Okay, am I audible now, sir?
Yes, go ahead.
Yeah. So I was saying that in tennis elbow, still you can use steroids for patients who are recalcitrant, for patients who don't have improvement with conservative management. I think a lot of us, including me, used steroids in them. Even literature-wise, there are a lot of meta-analysis where they say that you can use it, but the short-term results are good. Long-term results are not that great. Also, there was a query from one of the listeners that what percentage do you operate them? So for us, the percentage would range between, I think, less than 5%. 95% do very well with rehabilitation, which includes gradual stretching of the common extensor origin. Also, another thing that we have to understand is we have to diagnose tennis elbow very correctly, because like in Tarun sir's lecture, he was about the
Tejas, again, your voice.
Clinical diagnosis. Sir, if your patient, does he have instability? Because instability will also present with pain. And if clinically you have ruled out instability with your valgus loading test, then and on your MRI you see that there is ECRB tendinosis with sometimes even a partial tear of the ECRB, then probably I think once you have labeled your tennis elbow correctly, then treating them with a protocol, a tiered protocol of exercises. If they don't work, a single shot of injection. If that doesn't work, then probably an arthroscopic capsular release. Or for the people who are doing it open, the way Nerschel describes it, of excising the whole Nerschel lesion, the ECRB dysplastic lesion, that can also work.
Wonderful.
Sanju, can I answer this question?
Yes, sir, please.
I feel like in our practice, like we have been practicing for like now last 29 years in orthopedic. So we have seen this local hydrocortisone being used very commonly. And
Yes.
I would say the incidence of surgery or arthroscopic release or open release is less than 1%.
Okay.
And most of the patient usually get relieved with analgesics, or you ask them to avoid the sternus activities which cause this pain, and give them one or maximum two shots of local hydrocortisone injection with the complete explanation that they might get a depigmentation, and this depigmentation usually goes away within a period of 6 to 9 months.
Okay. What about the PRP?
I personally haven't used PRP till now.
Okay. May I ask to Chaudhary sir, Dr. Milind Chaudhary sir? As far as I know, I think he has a PRP centrifugal machine. Sir, what's your experience about that?
No, I actually reserve the use of these modalities for unhealed fractures. I do not believe much about the efficacy of this modality for tendinopathies, and it's very hard to promise, So I have reserved. I use platelet concentrates, but only taken from a blood bank initially, given by the blood bank for non-Indians. And now I use bone marrow only, but that is only for non-Indians. I do not use it for tendinopathies. I would hesitate to offer it to my patients, and I don't think it's been proved unequivocally. So thank you.
Okay. Literature differs a little bit over here. There are like reports which are showing that pain relief, a sustainable pain relief after PRP is much comparable. That after like steroids or even after the surgery takes longer time for pain to go, because healing process after surgery again is a lengthy process. But PRP, there are like many this industry people who are promoting such studies, but then obviously there is no common consensus about that as it. What about these masalas, supplements? Tarun sir?
I haven't used Sanju this for specifically for this tendinopathies.
Okay. They're saying like this collagen peptide type 1 in a ready-made form, if you give it, it will heal your tendons in a very quick fashion and all.
Somehow it is not believable.
Okay.
Whatever they say, or they give us some literature also for that, Sanju, but it is not believable.
But then patient wants something from you, some prescriptions from you, right? You cannot just keep them eating the analgesics, bombarding with the analgesics. So do you use these supplements?
No, I don't.
Okay. Even literature is saying the same thing. Like there is no clear consensus on this. But then clearly people are advocating about the use of vitamin C and the high protein diet for like vitamin C being the cofactor for the collagen synthesis, and this high protein diet for an enhanced healing. I think like I have seen prescriptions of Dr. Chaudhary sir, who is quite a regular prescriber for the vitamins, just the vitamin C he keeps on prescribing. Sir, your say on that? Milind sir? Am I audible?
I'm sorry, did I miss something?
Yeah. So I was asking about these nutraceutical supplements. Your say on that? You regularly prescribe vitamin C, that I know.
This is So if this is regarding elbow aches and pains.
Yeah.
Not a very specific. I find that a lot of elbow aches and pains are correlated with pain that originates from the cervicobrachial region.
Okay.
And if I can, if I can find this specifically, I do give the supplements. But if it's restricted to the elbow and generally they are osteoporotic and looking in poor health, then I would give. So we are trying to treat the patient, not the elbow sort of thing, you know. But not
Okay.
this. I'm not so sure about this. The specific medicines that are being prescribed for tendinopathies, I'm not very convinced myself.
Yes. So specifically, I'm discussing this because I see like many of our participants are the respected IMA general practitioners, and like it would be quite useful for them to know about the exact utility of these supplements. And they come quite costly, I think. They are not cheaper. So that is what the experts have to say about that. What about use of these braces and the exercises? Tarun sir, once again.
Yeah, I do give them this tennis elbow belt as well as this elbow caps.
Okay.
Yeah.
And can you just focus on like how it works?
I feel that I asked them to tie this on the extensor tendon just about 2 centimeter below the lateral epicondyle. This belt which is being shown, it is tied there. So I think it helps in reducing the stress at the lateral epicondyle.
At the tendon. You are applying it at the muscle belly so as to reduce the stretch on the tendon at common extensor origin, right?
Yeah.
Yes, and it is one commonly advocated thing. What about the exercises, sir?
Yeah, I usually ask them to stretch their tendon by like flexing and keeping the elbow extended and flexing the wrist. The stretching exercises I ask them to do regularly.
Yes. So something called as an eccentric loading exercises are specifically
they are called
designed.
as eccentric loading exercises.
Yeah, and apart from that, mobilization of your scapulothoracic articulations, strengthening of your shoulder abductors and external rotators is what is recommended.
Yes.
So that is the one thing again which works for most of the patient. What Tejas has said, like 95% patients, they do get better with the conservative measures, and these remain the one major modality to be looked after. What about the surgery?
Yeah.
Tejas, can I call you back again? You already talked about that.
Yes, sir.
This graphical animation is depicting something what we do in the open surgeries, which is surgery in any form. Normally for this epicondylitis is recommended only after an adequate conservative trial of not less than 6 months, right?
So conservative trial and a high demand patient, probably two things. So we have to look at whether
for high demand sports athlete patient, possibly you will go little earlier, intervene little early. But for the common general public,
sir,
you'll spend minimum 6 months.
High demand athlete would be 6 months. For a high demand athlete, it will be 6 months. And for a patient who has been suffering after multiple injections, probably 2 injections. In our practice, we see patients who have had 2 injections, they still have persistent pain, then I would go for surgery.
Yes. And as you rightly pointed out then, like picking up the involved tendon, like which tendon is actually pathological, you have to diagnose it clinically or on MRI before actually venturing into the surgeries. No matter whether it is open surgery or an arthroscopic surgery, the results are quite similar for both, but like arthroscopic, they say like the result, the healing process is much faster. Recovery is much faster in that.
Yeah.
So identifying the pathological tendon, like for the tennis elbow on the lateral aspect, commonly involved tendon described is the ECRB, extensor carpi radialis brevis, followed by an extensor digitorum communis. So this taste of cosens and means what Tarun sir has talked about will tell you about the ECRB status, and there is something called as Maudsley's. Registered extension of the middle finger will tell you about the status of EDC. And as we said, like arthroscopy is picking, arthroscopic debridements and repairs are picking up, considering their the rapid rate of the healing. any surgery, you have to keep in mind about this safe area, like which area you actually can debride, which is like a bisector through an radiocapitular joint. An area anterior to it is the area you will debride, because the area posterior to that bisector line has this one important ligament called as lateral ulnar collateral ligament, or LUCL, which is this most important posterolateral stabilizer of your elbow. So inadvertent surgeries or excessive debridements are known to give known to create iatrogenic instabilities even. So you need to be a little cautious about that. That is what they say. Am I right, Tejas?
Sir, bang on, sir. Absolutely agree with you.
So herewith, we'll conclude with this first talk. Now I'll invite our next speaker, Dr. Mandar Wagmare, who is pediatric orthosurgeon from our city, and I'll ask him to enlighten us on the pediatric elbow injuries of concerns. Over to you, Mandar. Start sharing. Mandar, share your screen, please.
Yes. Good evening, everyone. Thank you, Sanjay sir. Is my screen visible?
Yes.
Okay. So I will cover the topic pediatric elbow injuries of concern. So I will start with the most common type. Okay, so supracondylar humerus fracture is the most common type of pediatric elbow injury. It is broadly classified into two types: extension type and flexion type. So extension type classification is the Gartland classification. Type 1 is a non-displaced fracture, usually treated with a casting. Type 2 is a angulated fracture with intact posterior hinge. There is the anterior humeral line, the capitulum is posterior to it. So there's a this injury is treated. Type 2A injury treated with casting. Type 2B is the angulation with the rotation of the fragment, which usually treated with the post reduction and percutaneous spinning. Type 3 is a complete fracture. Is further subdivided into 3A and 3B. 3A is a posterior medial injury, posterior medial type. There is a spike laterally. So a buttonholing of the brachialis muscle and radial nerve injury can happen with this injury. 3B is a posterolateral type fracture with the spike of the proximal fragment is medial, and brachial artery injury or entrapment or medial or ulnar nerve injury or entrapment can happen. So this fracture requires a good initial assessment. So as both the neurovascular structures is at risk, so there will be three types of presentation. Patient will present with either with a white hand, so which is a pulse absent and poorly perfused hand, or a pink hand, which is a pulse absent but well perfused hand, and third is a everything pulse and perfusion is okay. And another thing we need to see is the neural assessment. For the motor, you need to can assess by asking the patient doing simple rock paper scissor. So a rock is to test the median nerve, paper is to test the radial nerve, and scissor is to test the ulnar nerve. Sensor examination can also be done by doing a light touch to the tip of the index finger for the median nerve, to the dorsal aspect of first dorsal infrashaft for the radial nerve, and the tip of the little finger for the ulnar nerve. So this type 3 fracture is usually treated with the closed reduction and with 3 pins. May require the open reduction also. Then there is also type 4 is described recently, which is a multidirectionally unstable supracondylar humeral fracture. In this is an intraoperative diagnosis. This distal fragment is on extension, it is a extend, and on flexion of the elbow it get flexed. So this usually happens because of the incompetent periosteal hinge, and it may most of the time require the open reduction. Then another type or another you can say type, the middle communication, the comminution type of supracondylar humerus fracture, in which there is a medial column is comminuted, and at presentation the patient will have the Cubitus Virus attitude. So this if treated conservatively can lead to Cubitus Virus. So should be treated with close reduction and pinning, often requires a significant valgus force for the fracture reduction. Then after completion of extension, then there is also flexion types of supracondylar humerus fractures, in which the distal fragment is flexed. This fracture usually requires open reduction, and ulnar now is at risk. So then another important point here to consider is the pin configuration. Usually preferred pin configuration is a 2 lateral divergent pin, 2 pins for the type 2 fracture, and 3 lateral divergent pin for type 3 fractures. You can use a medial pin, but you need to open it on the medially mini open incision. On the lateral, one of the pin should cross from the anterior to the posterior side. Avoid the configuration like pin which is not having any proximal fragment purchase, intramedullary pin, and pins which are converging at the fracture site. So the indication for the medial pinning is the medial oblique fracture, fracture with the medial comminution, high supracondylar fractures, fracture with the initial Cubitus Virus or medial instability, and very low supracondylar humerus fractures. Then comes the topic of pulseless supracondylar humerus fractures. So pulseless supracondylar humerus fracture with good hand perfusion can be first treatment is the close reduction and pinning, should be done at urgency. After fixation, and look for the any improvement, any deterioration of perfusion, and also look for the compartment syndrome. And if and you have to observe it for at least 48 hours. Similarly, the pulseless hand with vascular compromise is an emergency condition. You do for try to do reduction of blood and spinning, and look for the improvement in perfusion. If there is no improvement for perfusion, then do anterior approach and vascular repair. And if there is a improvement, then you again have to observe for at least 48 hours for any improvement or deterioration for perfusion or for any compartment syndrome. So Ital in his paper has described and has given a algorithm for the supracondylar humerus fracture with right hand. So I will now cover the next topic, the lateral condyle humerus fracture in children. So there is an old saying that this fracture is a fracture of necessity. So that means we need to fix each and every supracondylar humerus fracture. But now the real question is it true? So the answer is no. Now it has been demonstrated that a stable lateral condyle humerus fracture can be treated conservatively with cast. So first go with the classification. So common classification is the Mills classification. Type 1 is the fracture line going lateral to the trochlear groove. Type 2 is the fracture line going through the trochlear groove. Type 2 is a more common and is an unstable type of lateral condyle fracture. Then another classification is the Weiss classification. So he describes that 3 types. Type 1 is the fracture, lateral condyle fracture with less than 2 mm displacement. Type 2 is a fracture with more than 2 mm displacement with intact cartilage hinge, which is demonstrated on the arthrogram, arthrogram. And type 3 is the displacement more than 4 mm with a rotated fragment. Then another classification described by the song, which is now everyone is following worldwide. So they describe the 5 types of the lateral condyle humerus fractures type. And he also described the importance of the lateral internal oblique radiograph. So, so stage 1 or type 1 is the lateral condyle humerus fracture till the metaphysis, involving the metaphysis. Type 2 is the with the displacement less than 2 mm. Type 2 is the again displacement less than 2 mm. The fracture line extended till the articular cartilage, but it's an incomplete fracture. Type 3 is again displacement less than 2 mm, but the fracture is extended till the articular cartilage, and there is a medial gap. There is a lateral gap as well as there is a medial gap. So he says that from type 3 onward, they are the unstable injuries. Type 4 is the displacement more than 2 mm, more than 2 mm, and is the unstable type. Type 5 is the displacement more than 2 mm and is the displaced and rotated type. So he also gives the algorithm for the treatment. So from stage 3 onward, stage 3 and onward is required the operative fixation. Additional imaging having the role in the for the management of the lateral condyle. So this is the MRI of one of patients having the lateral condyle fracture with intact cartilage hinge. So it's a stable fracture. Then another patient having a fracture with the disrupted cartilage hinge. So it's an unstable fracture. Unstable fracture should be operatively treated. So management of the lateral condyle is that we can do casting, we can do close incision pinning, we can do open reduction and pinning. Okay. The point to consider here is take the assessment other than standard radiograph, take the internal oblique radiograph, confirm the fracture type so that you can go to the management. So surgical avoid the mild reduction as they are most of them are the intra-articular injuries. So you should have low threshold for opening. Don't dissect the posterior aspect of the fracture fragment to avoid the AVN of the fragment. And also follow this fracture till the clinical union, as they even after surgery they tend to go into non-union. So you need to see a post after 2 months whether the fracture fragment is a tender or non-tender. Okay, so pin configuration, preferred pin configuration for the lateral condyle is the 2 divergent pin at 60 degree of angle or 3 lateral divergent pins. Then the most common complication after fixation of the lateral condyle is the lateral bump or lateral spurring. So it occurs in 73% of the cases, but it does not cause any functional or ROM deficit, but it do causes a parental concern. So you need to counsel the parents pre-operatively that it may happen and it is a benign condition. So then comes the treatment for the chronic non-union. So chronic non-union usually treated with in situ screws, and if they are associated with cubitus valgus deformity of more than 25-30 degree, then with in situ fixation into the supracondylar osteotomy for correction of angulation. Okay, so after completing the 2 common topic, I would like to focus on some serious issues that can happen with the elbow. So Peter Waters in his paper Elbow Trash, TRASH, the radiographic appearance seem harmless lesion, describe the some groups of the osteochondral injuries, which are the radiological appearance of these injuries are innocuous because there is nothing there is all normal or non-serious on the radiography because they are not ossified only. So but they have been grossly displaced and they are unstable. So if they treated insufficiently, they result in chronic long-term consequences. Usually present with the swollen elbow, there is a gross restriction of motion, and many of the time they are associated with high energy trauma. Diagnosing them requires a high level of suspicion, and also additional imaging is required. And all of this flash lesion requires anatomic reduction and internal fixation. So for this diagnose a flash lesion, they just तेजस सर आपका तेजस सर अनम्यूट कर.
Tejas, mute yourself. Tejas, please mute yourself.
Okay, so to diagnose the trash lesion, you need to know the ossification center. Ossification centers around the elbow. There are ossification centers. The mnemonic to it, the CRITOE, crito. So once you know when at what time this appears, so you can easy to diagnose the injuries around the elbow. So let me start with the one of the example of trash lesion, which Peter Water described in his paper. So this is a 3-year-old child with a swollen elbow, and with a restriction of supination. On the radiograph, you see there is some irregularity at the metaphysis. On additional imaging, found to have a completely displaced radial head. So it is a radial neck fracture with the radial head dislocation. So we need to do the reduction and fixation for this fracture. Another is a 5-year-old. Another is a patient with having radiographically looks like a medial epicondyle injury, but his age is only 5 years. So in 5 years or any children below the 7 years, any epicondylar fracture is a medial condyle fracture until proven otherwise. So actually in this case, there is the whole of the condyle is displaced. Along with this is the metaphyseal fragment. Another example there's a radiograph showing a huge medial swelling, and there is some specks of bone here can visible. So for him, additional imaging taken, and they found to have the MRI film found to have a completely flipped medial condyle fracture. So it's treated with open reduction and tear fixation. Another radiograph. Right side is the injured and left side is the common normal side. So physiologically it looks like a elbow dislocation. But if you observe it carefully, if you draw the line here, the radiocapitellar line is crossing, the radiocapitellar line is maintained. So it is described as a transfacial separation. It's not a elbow dislocation. Because the radiocapitellar line is maintained in two types of injuries, in a supracondylar injury and with a transfacial separation. The radiocapitellar line is disrupted in a elbow dislocation and in the lateral condyle humerus fracture. So this transfacial separation is reduced and treated as a low supracondylar humerus fracture with crossing. Another trash lesion, 11-year-old patient with elbow dislocation. It is reduced closely, and there is still incongruity at the joint and some fragment inside the joint. So pediatric elbow dislocation are mostly complex dislocations most of the time, and there is the associated epicondyle, medial epicondyle fracture fragment which get entrapted into the joint, and you need to do treated it with open reduction and internal fixation of the fragment at its original site. Another very important trash lesion is a 9-year-old child with 1 month post injury, still having a lot of stiffness and restriction of pronosupination. If you draw the radiocapitellar line, the capital line is going posterior, and there is some small, we say minimal fracture here or a minimal injury here. But when you do MRI, you see there is a radial head interarticular fracture with posterior subluxation of radiocapitellar joint. So this fragment need to do fixation at its site with Herbert screw. Then another type of fracture of interest is a Monteggia fracture. So Monteggia fracture, we all know there is a ulna fracture with the radius dislocation. So here the concern is when to do the only plaster, when to do intramedullary nailing, when you put the plate. So algorithm for that is if there is a ulnar plastic deformation or ballistic fracture, then you do close reduction casting and do radiographic monitoring of the radiocapitellar joint. It is a length stable ulnar fracture, a short transfer short oblique ulnar fracture. Then you can put intramedullary fixation after close reduction and casting. And if the length unstable fracture, then you do open reduction and plating. Okay, so there's a Bardo's classification is given the types for the Montegia. The type 1 Montegia is a classic example of the type 1 Montegia, in which there is a anterior, so the radiocapital line is anterior. So here, as this is a green stick ulna fracture, this is treated with the close reduction and casting. But casting we need to do in type 1 Montegia fracture in a hyperflexion, because at 90 degree of flexion, in 70 degree of flexion, you can negate the bicep pull. Another example of type 1 Montegia fracture. Here is again the radiocapital line is disrupted. The radius is lying anterior to it. This looks like it is only the radius dislocation and there is no ulna fracture. This is acute injury. But if you draw the line, known as Mubarak's line, the ulna is anterior to it. Usually the posterior touches this line. So there is a plastic deformation of the ulna. So treatment for it is to correct the ulna deformation, and then the radius will get set back on its own. So you need to give a sustained traction of about 4 to 5 minutes at least to get the ulna back into its position. And if you give a less minimum time of traction, minimum time of force, then again spring back to its original deformation site. So 4 to 5 minutes is minimum required for it. And again after reduction, again gives the cast in a hyperflexion position. Then type 2 Montegia.
Can you wrap it up faster?
Yes, sir. Okay.
Can you wrap it up fast?
Yes. Type 2 Montegia is the opposite of the type 1 Montegia, in which there is a ulnar fracture with the posterior dislocation of the radius. As it is opposite of the type 1, so you need to do reduction and give the cast in extension. Involves the thumb in the plaster and do supra condyle molding to prevent the cast slippage. Then type 3 Montegia is the lateral dislocation of the radius with the ulnar fracture. So you may need to open at the radial side, because sometimes post-introsseous nerve entrapment can happen. Also there is a tendency of the ulna to for the radial deviation. So if the ulna is unstable, then you better to do intermedullary fixation. Miss Montegia also common. So they treated with the ulnar osteotomy. So ulnar osteotomy, better to do ulnar osteotomy proximal, give distraction and angulation. And if the radius head is set back, then only ulnar osteotomy is sufficient. If it is not, you need to do open reduction. You need to do ulnar annular ligament repair or reconstruction. There's a for conic Montegia, 2-3-year-old Montegia, the Donald Bay has described an extended posterolateral approach. There's a single incision which is used to assess the radial nerve, radiocapitular joint and ulna. Then another topic I took is the radial neck fracture. The classification for the radial neck fracture is Jude classification. They describe the 5 grades depend upon the radial head angulation and translation. Operative fixation for the radial neck fracture, the indications are angulation greater than 30 degree, translation more than 50 degree, and in the older children. So management methods are either closed, you do assisted close, or open methods. So try least invasive method, try close, if not an assisted close, and then open method. Complication is there are a lot of complications for this fracture: the loss of motion, stiffness, radial head overgrowth, and avian premature closure of the fasciitis Cubitus Virus. So a song has described percutaneous method for severely displaced radial neck fracture. So use the pin to stick the fragment. You have to get the pin lateral and over the ulnar border of the radius to avoid the pin which is anterior. And what it does, reduce the fragment and put that same pin in the far cortex and keep that pin for 10 to 12 days and cast it for 6 weeks, 4 to 6 weeks, and that's how you manage. Another way you can do the joysticking and put the wire. Metasio technique you can use. So if there is a unsuccessful close or assisted close method, the radial head should put back by open reduction. Poor result following open reduction is mainly due to the initial trauma. So to summarize, the proper clinical assessment is needed in the elbow injury. The mode of injury with the high energy trauma you need to know. Then you need to do the radiographic assessment, take the additional radiographic views, draw the lines wherever necessary. The knowledge of the ossification center is a must. Additional imaging like MRI is needed sometimes. Thorough counseling about the potential complication is also the must, and regular radiographic follow post-operatively is also must. Thank you.
Thank you, Mandar.
Thank you.
Yeah, so many new things we learned, the general orthopods, like so many rare lesions, the physeal separations, which are easy to pick on the routine X-rays. You nicely covered them up. So after your today's teaching, can I safely label it as a...
connections आते हैं तुझे?
Am I audible now, sir?
Yes, yes.
So Mandar.
Yes, sir.
With your recent teaching, can I safely label this as a transphyseal separation on X-ray itself, or you differ with it?
Yes, sir. Looks like transphyseal.
Transphyseal. Yes, how do you manage it?
The transphyseal, we do the arthrogram intraoperatively and pin it. If it is acute, is within 3, 4, 5 days. If after 5 to 7 days, if it gets chronic, then you just need to observe it. It will get remodeled most of the time.
So in simpler words, for the sake of benefit to the general orthopods, there must be many participants here. Can we safely say like your orthogram is mandatory in this situation where like physis is totally unossified and you won't be able to judge the reduction per se? Yes, so sir. Arthrogram is the most important thing to do, and under that orthographic evidence guidance, if it is reducing close, you will do a close pinning, or if it is not reducing well, should we hesitate in opening it up, or can we open it up? This sir, being a growth center.
Yes. So actually, if it is acute, then only you go for the fixation. If it is older than 7 days, no, then it already gets sticky, and transphyseal separation happens in very young patient usually.
Right.
So 7 days, there is no role of doing means opening that. So do it close. If it is acute, do it close with arthrogram.
So those neglected transphyseal separations who comes to us, so like many of the time parents are not like they don't pick it up in the early stage. Yes, so sir. If they come late, how to deal with it?
So explain them that most of the time they get sticky, they won't come, sir. So
do the remodel well.
Yes, sir. They do remodel well. That's why we need
to, elbow will be not that bad.
Not that bad. Yes, sir. Yes, sir. Definitely.
In spite of any amount of the displacement.
Yes, sir. Yes, sir. Especially this transphyseal separation, at birth they happens.
Yeah.
Yeah. So and they come to us very late. After 5-7 days, they're moving because they are in the NICU for some other reasons. And
right.
When they come to us, it already gets sticky and child already start moving. There's a maybe swelling, but they already start moving. So we just need to observe
most of those are like admitted in NICUs for some neonatal sepsis and all.
Yes, sir.
Could there be a DD in the form of elbow pyogenic arthritis or something like that for such a widening if you get to see?
Yes, sir. Yes, definitely there will be some.
Yes. Quickly, the other case I'll put. You have already shown it. The yes, same, like, let me ask first, like, how common are the dislocations, elbow dislocations in pediatric age group?
Sir, not very common.
Right. So this was 9 years old boy. Came
yes,
to
sir.
me with this presentation, and as you said, like there after close reduction also, if you get to see such kind of mushy reduction, what I'm supposed to do?
So you need to open it, deliver the fragment out, yes,
right,
and
right.
then put that fragment back to its original position, and then elbow get reduced.
Yes. So this dislocation was an outcome of medial epicondylar apophyseal separation, and along with the common flexor origin, it has like
Yes.
it was like intruding inside the joint and
Intruding
not
inside the
letting it
joint.
reduce nicely.
Yes. Yes.
So open reduction and fixation with the screw.
Yes.
6-year-old boy, almost 2.5 months old, neglected injury, comes to me with this picture.
Okay.
Mild displaced lateral condyle. How should I go?
So you need to open it, reduce it, and explain them there may be a stiffness for some time, but you need to fix it because it looks like non-uniting. There is a gap. You still 2.5 months and there is a gap laterally. The metaphyseal union has not yet happened.
Right.
So this need to
you need to support it.
You go anteriorly, you minimally dissect the fragment and don't and whatever, if it is come then it's good, or otherwise do whatever reduction you achieved and fix it with screw.
Good.
Metaphyseal screw, yes.
Right. So same way I did that open reduction, but like because it was 2.5 months old neglected, what I did is like I took little bone graft from the same adjacent olecranon. I put in between and then I fixed it with the K-pins. Even screws are recommended. And as you said, like that the lateral leaping that occurs in the healing process is a quite common phenomena, which is not deterrent to any function as such.
Yes.
You also covered on these pinnings because like most we general orthopods, it is a routine bread and butter for us, supracondylar fractures. I so thought of like just emphasizing more on these pinnings. These two lateral pins put in a very close divergent manner, they tend to be rotationally unstable and they are strictly no. This particular pin placement is not recommended.
Yes.
Ideally, your pins should be divergent to the distance of almost third of your fracture width, like that. That is an ideal placement if you are like relying on just two lateral pins. The other constructs, 2 divergent pins, 3 divergent pins in some special situations, or medial and lateral pin, collateral pins. He has already covered it. If there is a fracture obliquity, fracture is normally we get to see in a transverse plane only, but they are like if oblique fractures, if the obliquity is high lateral, you will put these 3 pins from the lateral side. If it is high medial, you will put cross K pins, 1 pin from the medial side. Due diligence, because there is ulnar nerve at risk. Normally, it is not recommended to put it percutaneously. Take a small incision, push your ulnar nerve back properly, and then put that in. So thank you, Mandar, once again for such a nice talk.
Thank you, sir.
Now we'll move on to the next talk, where we all know that elbow is snugly surrounded by these vessels and multiple nerves. These elbow injuries, they have an inherent potential to injure those structures. So how do we deal with these neurovascular complications? I'll invite Dr. Deepak Malokar, who is an eminent hand and microvascular surgeon from our city. Over to you, Deepak. Deepak, can you hear me?
Yes, sir. Thank you, sir.
Yeah. Please share.
So, good evening, everyone. So, I'll be talking because both nerve and artery will become a big topic. So, I decided to just deal with the vascular injuries around the elbow. So, rather than starting with theory, I will directly start with the practical scenarios. So, the most common call I get is these injuries. So, this is a 5-year-old male child who had sustained this fall on an outstretched hand. And he was referred to me by my surgeon from outstation in view of absent pulse. Even when I examined this patient, it was pink hand and pulse was not palpated. But the moment I used a handheld Doppler, there was a distinct pulse which can be heard. So this forms the first principle of our dealing vascular injuries, that never believe your own finger. Whenever you are dealing with vascular injuries, the best instrument to assess the vascularity is the handheld Doppler, because whenever vascular injuries occur, the pulse become monophasic, which are difficult to palpate digitally, and even sometimes hypotension is there, and extremity palpation of the pulse on the extremities is difficult. So never believe your own finger. So in this case was not a pink pulseless hand. This was a pulsed hand. So this was just fixed closely, 3 pins, and this is how it became at around 1 year, and that's her range. So moving on to other case, this was again similar case, supracondylar humerus fracture. Again, I got a call. This was her X-ray picture. Now, in this case, also there was pulse was not palpable, but the hand was pink, and even the pulse could not be detected on a handheld Doppler. So, in these cases also, where the hand even Doppler cannot detect pulse, what we have to do, we have to fix them percutaneously first, and then what we have to do is to assess the pulse after reduction. Now, in this case also, once the reduction was achieved and it was fixed, the pulse reappeared. So this forms our second principle, that is reassess the vascularity once the fracture is fixed, or in case some joint is relocated. If it is dislocated, we have to relocate the joint in casualty itself and again reassess the vascularity. Even if pulse is not there, then only it's a vascular injury case. Otherwise, there is no injury to vessels. Now, again, third case, around 6-year-old female fall on outstretched hand. This patient again did not have pulse distally, but the hand was pink. So this was fixed with 3 pins. Post reduction also, the pulse did not return. Now, in these cases, what we have to do, especially in supracondylar humerus fracture, that forms our third principle, that you should never chase the pulse. But what matters is the perfusion. And how do we check for this perfusion? So the first thing on inspection, we have to see for pinky fingers. The next thing is on palpation, you have to check for warmth, whether the hand is warm or cold. Then you have to also check for capillary refill in all fingers. And finally, with the instruments, that is multipara monitors, you have to check for SpO2 and also waveforms, like in this case. So we have a SpO2 of 100%, and there is a good waveforms present, waxing and waning. So that indicates this hand is very well perfused hand. And in spite of absent pulse on handheld Doppler, we need not do any intervention. So this patient at 6 weeks, the fracture united and the pulse reappeared at around 3 to 4 weeks. And this is how her function was. Now moving on to next case, this is a posterolateral injury to the elbow with an open fracture of lateral condyle, and this patient also did not have pulse even on examination by handheld Doppler, but the distal part was pink warm, so the capillary refill was good, so it was a well perfused hand. So what we did, just to document, we did a CT angiography, because it is considered to be the gold standard whenever we want to investigate the vascular injury cases. So in CT angiography, it showed that there was a segmental block in the brachial artery with distally, there was not a very good collaterals, but then there was some perfusion distally. So what we did, just minimal fixation of the lateral condyle with 2 divergent pins. And on exploration, he had a complete rupture of biceps, brachialis, brachial artery, common extensor origin, posterior interosseous nerve, and lateral condyle was also fractured. So all these things were repaired except for brachial artery. So this was fixed. This is at around 6 weeks. This is post-op X-ray. The wounds healed very well, and this is at union, and this is post K-wire removal. At around 9 months, the fracture united very well. He had a good range. The PN also recovered very well, and this was his supination, pronation. And now you can see the hand is very well perfused, and here you can see at around 9 months, the pulse is very well written, like pulse is written, and it is documented on handheld Doppler. So what does this signify? So whenever vascular injury is there, vascular repair is not necessary, even if it is documented on a CT angiography. But then provided we have to check for 2-3 things. That if it is there, if there is any wound, we do not extend the existing wound, because by extending the existing wound, we are damaging the collateral circulation, and we may jeopardize the distal vascularization. Whenever the fracture is there, we have to always treat it closed or a percutaneous manner. If we fix it in an open manner, then again we are jeopardizing the distal vascularization. And always we have to try to do minimum essential fixation. Like in this case, we had fixed only 2 K-wires rather than putting a plate. Now coming to last case. So this is a case, again a thresher crusher injury with an laceration around the elbow. And on X-ray, he had a distal humerus shaft fracture. Now when we assessed him, the distal pulsation was not there. Even on handheld Doppler examination, the distal part was cold, capillary refill was absent, and when we checked on multipara monitor, there were no waveforms. And SpO2 could not be detected. So now this is an emergency case. And when he reached to us, it was already 5 hours old injury. So in such cases, do we do a CT angiography? So the rule is CT angiography should only be done if it is available in same hospital, or if it can be done within 20 minutes. We cannot spend more than 20 minutes in a vascular injury case which needs emergent exploration. So because this was done in a other hospital where CT angiography was not available, we emergently took this patient inside the OT and we explored it. The debridement was done. Here you can see 2 ends of the brachial artery with almost around 6 centimeters of gap. After exploration, the fracture was fixed with a plate, with 2 plates, because it was quite distal. And then saphenous vein graft was harvested from the ipsilateral limb, and then the reconstruction of brachial artery was done. Post repair, now here you can see the pulse return, and the part was warm, and on probe you can see the SpO2 is 100% and has got good waveforms. Luckily, all wounds survived, and this is how he became at around 3 months with almost everything healed up. So in essence, whenever you are dealing with vascular injuries around elbow, never believe your own finger, always examine with a handheld Doppler. Reassess the vascularity once the fracture is fixed or joint is relocated. Do not chase the pulse, but look for perfusion. CT angiography is the gold standard. Vascular repair is not always necessary, and CT angiography should only be done if it is available in the same hospital or if it can be done within 20 minutes. Thank you.
Thank you, Deepak. Nice and crisp reports.
Thank you, sir.
So, any questions from the panelists for Deepak? Deepak, let me share this one case from one senior surgeon, Dr. V.N. Deshpande sir from Ahmednagar. Actually, I share one group with him, and there he posted this case recently, this week itself, where the young boy presented to him in middle of the night with this tiny compound wound over there. Supposedly elbow was relocated at the very first X-ray, but he didn't post that, so I don't have that. But it was obviously an unstable elbow. And then Doppler they did. Doppler was mentioning something about like a thrombotic occlusion of a segment anterior to the elbow, and the CT angio was like this. So how to differentiate an actual rupture and a thrombotic occlusion? Is it possible to differentiate clinically?
Sir, best way is to just explore the artery and see for itself.
Okay.
It is very difficult whether the segment is thrombotic or whether it is ruptured, or it is very difficult to diagnose like on radiological basis, sir.
Okay. So here we can see on CT angio that distal radial as well as ulnar arteries are nicely filling up.
Yes, sir. Yes, sir.
So can we say like a good collaterals are there?
Yes, sir.
Supporting
Definitely.
the distal vasculation. So how would be your approach with this case? Like how you will go ahead with?
Sir, what I
It's
will
the middle
do,
of night. It's middle of the night, huh?
Yes, sir. Yes, sir. What I will do, like because he has, I will again check like on inspection whether the things are pink, whether the on inspection, on palpation it is warm or not, and on SpO2 whether it is picking up on waveforms, how is the SpO2, and third thing is checking on handheld Doppler. Like all these things are are positive, like distal vascularity is good, then there is no need to do a vascular repair. Just do a good debridement, relocate the joint, and manage it percutaneously. Like if it is unstable, just put an external fixator, or if it is remaining stable, just put a slab. If you are doing a like this percutaneous thing, there is no need to do a vascular repairs.
Okay. So you mean to say like not to open it up so as to preserve the collateral circulation, right?
Yes, sir. Yes, sir.
Okay. There was one question from the participant actually at the very first, at the beginning of your talk only, that how much this handheld Doppler costs?
Around 35,000, sir.
35,000. Okay. And in case like this case turns out to be a rupture of the brachial artery, main trunk, without much of the collaterals distally and ill perfused or a non-perfused limb distally, how
Yes,
you
sir.
will go ahead with?
So then you have to do a formal exploration.
Okay.
The thrombotic or occluded segment has to be excised, and this much part has we have to use the reverse saphenous vein graft.
As you showed in earlier case.
Yes, sir. Yes.
And that you will be doing utilizing that compound wound over there and some lazy sort of an anterior incision.
Yes, sir.
At
Yes,
the
sir.
anterior aspect of the elbow.
Yes, sir. Yes, sir. Definitely.
Okay. When you are opening it up, your look out for this outlook for this managing this instability in the same time. At the same time, will it differ, or still you will think of just putting a K-wire, stabilizing it temporarily, and then to deal it in a later stage?
Yes, sir. I will always, whenever we are dealing with vascular injuries, management of bone injuries generally takes a back. Like they can be addressed later, rather than doing a thorough job at the same sitting.
Okay.
Because it is like
so
a house on fire.
Here it is not a bony situation. There are, I mean, hardly a leap of the radial head seems fractured over there.
Yes,
so
sir.
it was more of a soft tissue avulsions, like the maybe this ligament injuries only on MCL and LCL.
Okay, sir. Okay.
So when you are creating the flaps, will you think of repairing those ligaments in the same time, or you will not?
Sir, definitely not. Because if you are talking about ill perfused or non-perfused distal part, then we have to treat it like a house on fire. The more time you spend on bony fixation, then you are losing on time, sir. So we have to just, so generally they say whenever a distal part is non-perfused, generally they give around 20 minutes for bony fixation. You have to just wrap it up fast, because the golden hour is only 6 hours, sir. If we extend more than that, then the chances of reperfusion injuries are more, which are like life-threatening.
Yes. Okay. So this was about like acute neurovascular compromises. you have not covered about these chronic sequelae of the ischemia that one tends to get with not that commonly nowadays, because these supracondylar fractures are emergently managed by every orthopod now.
Yes,
But
sir.
like once in a while, we'll keep getting these VICs, Volkmann's ischemic contractures.
Yes, sir.
Can you just quickly enlighten about the management part of these presentations?
Sir, this topic itself is very big, sir.
Okay, so we'll skip on that.
Yes, sir. Yes, sir. Better to skip.
Okay, but I just included this with one query actually. Normally, this was mild to moderate presentation. I went ahead with the flexor muscle mass slide extensively, neurolysis and all. A good restoration of the functional length. But this is like almost 3-4 years down the line. The boy is again contracting.
Okay, sir.
So is it a common presentation?
Yes, sir.
That
Yes,
they
sir.
tend to recur with the contractions?
Yes, sir.
Contractures?
Sir, what age did you do this?
I must have done this at he must be 7-8 years old then.
The
Now he is
problem with
almost 10 years.
this child is the already ischemic muscles, they do not grow as per the normal muscles, sir. So as the height of the child increases, it again forms contracture. So it is quite common to get this.
So how to think about it now?
Sir, what I think is again,
luckily the boy has adapted well with his left hand now. He was right-handed to begin with,
okay,
but
sir.
now because it is almost a dysfunctional hand, in spite of having a good length and all, but there is no dexterity in his right hand. So he's well adapted and adjusted with the left hand now.
Okay.
So how should I look at this now, the recurring contracture?
Sir, what I will suggest is to let him become mature first, skeletally mature first, and then reassess his thing, and then we can address the contracture. Then now, at the time of skeletal maturity, if we address the contractures, there will be less chances of having recurrence.
So what would be that age?
That must be around 18, sir. 18.
By 18. So not to touch him again till the age of 18, right?
Yes, sir. Yes, sir.
Yes. Okay. Thank you, Deepak.
Thank you, sir. Thank you.
Yeah.
Deepak,
So now,
there is,
yeah.
sir, sorry to
Yeah,
interrupt.
Tejas. Yes,
There
yes,
is a question from the audience for Deepak, that what is the cost for the handheld Doppler?
Sir, 35,000.
Okay. Thank you.
Thank you, sir. Thank you.
So thank you, Deepak.
Thank you, sir. Thank you.
Now, where like pediatric elbow has many weak links to get the separations or the fractures to happen through, adult elbow is something like a well-developed and well-ossified bones, and they are stronger enough to resist the stresses of the injuries. But there is some, like, bone is strong now, but there are like some weak structures in the form of soft tissue. So how do they differ in the management or the presentation? Let us listen from one eminent senior orthosurgeon from our city, Dr. Sanjay Sonawne, sir. Over to you, sir. Sanjay, sir. Sonawne, sir, can you start sharing? Is it there?
Hello, Sanjay.
Yeah, yes, sir. Please go ahead.
Audible.
Yes, sir. Yes, sir. Start sharing.
And share. Can you see my screen?
Yes.
Okay. Good evening, everybody. Good evening, friends. Thank you, Sanjay, for this opportunity. The topic given was this elbow injuries in adults, quite a vague and a large topic, I would say. I have tried to summarize most of the important injuries in short. In the beginning, you have stated, but the audio, it was not audible. So I would just brief this, that the functionality of the upper extremity relies on elbow motion. if a person's elbow motion decreases by 50%, they say upper extremity impairment increases by as much as 80%. The elbow controls flexion, extension, and pronation, supination of the forearm, where in the flexion and extension, it happens at the ulnohumeral joint, and pronation and supination, they are at the radiocapitellar and proximal radioulnar joint. We know there are three bones, humerus, radius, and ulna, and this they call as a trochangiogmoid joint, or there are three joints. It's a complex of three joints, which is ulnohumeral joint, which is a hinge type of joint. There is a radiocapitellar joint, which is a ball and socket type of joint, and radioulnar joint, which is a pivot type joint, all of which lie within the same capsule. So elbow is a complex joint. We need to understand while planning the treatment, what are the stabilizers of the elbow. There are two, static and dynamic. And in static stabilizers, there are primary in the form of ulnohumeral joint, medial collateral ligament, especially the anterior bundle, this one, and the lateral collateral ligament, especially the ulnar lateral collateral ligament. And there are secondary static stabilizers in the form of radiocapitellar joint. This radiocapitellar joint is the important constraint to valgus strain. Radial head is the second important constraint. The capsule, its contribution is more when elbow is extended. Both flexors and extensor tendons, they are also the secondary static stabilizers of elbow. The dynamic stabilizers are anconeus, brachialis, biceps, and triceps. They provide compressive stability to the elbow joint. What are the injuries of concern? Radial head, olecranon, a combination of injury in the form of elbow dislocation, radial head and neck fracture, as well as coronoid fracture, what we call as steroid triad, we will see in the end. Fracture supracondylar humerus and elbow dislocation. Elbow is the second most dislocated joint after shoulder, with fracture associated with almost 25% of dislocation. Considering the limited time available, the elbow dislocation discussion is limited. To start with the fracture olecranon, it forms the 10% of upper limb fractures. If there is direct blow, that it can cause comminuted injury. If it is indirect, by the forceful contraction of the triceps against resistance, there will be avulsion fracture of the olecranon. All olecranon fractures by definition are intra-articular fracture, and that's the reason non-operative treatment is rarely indicated. But if the fracture is not displaced and it doesn't displace at 90 degrees of elbow flexion, we can treat it conservatively with the form of above elbow plaster with 45 to 90 degrees of elbow flexion, not for more than 3 weeks. We can start mobilization as early as 2 weeks, but by 3 weeks, the chances of displacement of these fractures are less. By and large, it needs surgical treatment, and the goals are anatomical reduction, congruent intra-articular reduction, rigid fixation so that we can start early mobilization of the joint. Different modalities of treatment. This is a tension band wire, very standard method, which we use at many places like fracture patella. So here the tension band construct converts the tensile distraction force of the triceps into the compressive force at the articular surface. This is self-explanatory, I suppose. These are the wires, and this is the cerclage wire. We can go use the screw here, or we can go through the bone. Few people, they use intramedullary screw. You can add a tension band wire on this. If the fracture is going distal, or if there is extension to the shaft, as a rule, if the fracture is distal to the coronoid process here, and if it is comminuted, in addition to tension band, or isolatedly, you can use additional plate. This is a old case where the hook plates were not available, so we treated this with a reconstruction plate. But these days, hook plates are available in market, and you don't need to add a tension band. Next, to discuss about fractures of the radial head and neck. It's again a very common injury, and it is present in about 30% of all elbow fractures, and it forms 3 to 5.4% of all the fractures in adults. Whenever it is possible, preserve radial head. In this case, these are the pre-operative X-rays where the radial head is tilted. These are the C-arm images wherein we have taken entry of the nail in the distal radius and in a retrograde fashion, in a flowered way, we inserted 2 nails, and this has helped in reduction as well as in maintaining the reduction. These are the post-operative X-rays, and you can see the flowering of 2 nails. These are the 2 small nails. So this is Metazu technique. We can fix these fractures with 2.4 mm mini fragment screws or headless compression screws as shown here. These are the mini fragment screws, which are 2.4 mm mini fragment screws. In some cases, if you feel that preservation is must because of the unstable elbow or because of the instability, and it is difficult to fix the fragments with screws and you don't wish to replace, you can fix it with mini fragment plate, the way it is shown here. And again, if we cannot save the radial head, so we need to give a stable elbow, then radial head replacement is definitely one more option. But certainly, as I'm discussing this in adults, radial head replacement would be reserved for geriatric patients. Next interesting topic is again fracture capitulum. This fracture capitulum, sometimes if X-rays are not taken properly, we may get confused with fracture of the radial head. In lateral view, if we see there is only one fragment, this shows that this is an isolated capitulum fragment fracture. If you see 2 lines, because in AP, many times we can miss this injury, but in AP, if you see 2 lines, this means there is involvement of capitulum as well as trochlea. So what we call as double arc sign. If still we are not clear, we can go for CT to understand the fracture geometry. This is the lateral approach. And herein, this is the proximal part, this is the distal part, this is the radial head. We have elevated the soft tissue from the edge of from the lateral edge to expose the capitulum. Then we reduced it in place and then fixed it with posterior to anterior 2 mini fragment screws. We have certainly option of going from anterior to posterior. Headless compression screws. These are the post-operative X-rays. Here the caution is not to disturb the posterior soft tissue while elevating the soft tissue from the lateral edge because we don't wish to compromise vascularity of the capitulum fragment. Moving on to further complicated injury. This is AP and lateral views of a patient, of a young patient. But many times we cannot define the fracture well just on plain X-ray, where CT is of great help. Here we can see it's comminuted lateral condyle along with comminuted capitulum along with comminuted trochlea. So this is again a very challenging injury and challenging in the form of how to approach this fracture, how to fix both. In this case, we used posterior approach with low olecranon osteotomy. Hyperflexion of the elbow helps to expose the anterior fragments, even though we may not see the fragments, but with the finger, we can palpate them. We can see the reduction, we can feel the reduction, and then we can fix them with multiple K-wires and mini fragment screws as shown here, and then we close the olecranon osteotomy. This is 9 weeks post-operative X-rays. And even though patient was having such bad injury, This is the functional range. Another patient, a 45 years old male patient, closed injury, comminuted distal humerus fracture. Now, in addition to comminuted this lateral condyle, comminuted capitulum, and trochlea, there was additional injury of the comminuted olecranon fracture. So, my role of olecranon osteotomy, it was by injury, it was a bit simple. So CT, again, 3D CT is must to understand the fracture in a better way. So there was comminuted lateral condyle, fracture capitulum, trochlea, medial humeral condyle, as well as olecranon. So all possible injury patterns. Again, and in this case, we were having no choice rather than going by a posterior approach, as we need to address the olecranon. Fortunately, we could do reasonably decent job. And this is 7 months follow-up. He's a steno working in court. I was a bit skeptical in treating a man working in a court. Another patient now, from intra-articular, we are going extra-articular, comminuted TY fracture, compound injury, debrided the wound and fixed it. Relatively, fragments are larger, so we were having better space for fixation, and we could use 2 plates. These are the intraoperative images. Very comminuted fragments, but the column fragments were larger. The primary fixation with multiple K wires, and this is before closing the olecranon. These are the C-arm images, and this is 10 weeks post-operative image. Moving to last and very interesting topic of terrible triad of elbow injury, which is nothing but a constellation of posterior elbow dislocation, coronoid process fracture, as well as fracture of the radial head. It occurs primarily in adults because flexibility of ligaments in children make this injury unlikely. Primary and secondary stabilizers are disrupted, and this is what makes this injury terrible. It is extremely unstable. There is loss of joint congruency. There is instability. Fracture fragments are usually quite small, so difficult to repair. And patients, they don't routinely do well. They are unaware of the magnitude of injury. There is a residual instability and secondary arthrosis, and many patients in long term, they get significant elbow stiffness. Treatment wise, we have a dilemma of surgical techniques which are challenging. There is debate in surgical steps and in choices of management of this injury. Mechanism of injury: fall on outstretched hand and with a valgus, supination and axial compression. CT, again, almost in any complex, as a rule, we do CT. This is the lateral view, a dislocated elbow, comminuted radial head, medial view, and this is anterior and posterior view. Can we treat terrible triad conservatively? Very rarely. If you feel there is no mechanical block associated with radial head fracture, the reduction is concentric, if coronoid fragment is small and the arc of elbow motion is stable, that means it doesn't dislocate at 30 degrees of full extension, we can treat it conservatively. But most of the cases, it needs surgical treatment. We need to work primarily on lateral side. We need to work from outside to inside. We need to stabilize in reverse order. That means from inside to outside. We'll discuss that. These are the 3 approaches: Coaches, Boyd, and Kaplan. Kaplan is one which helps us to reach the coronoid process comfortably. As we said, we'll start from the lateral aspect. We'll expose the joint. Radial head fragments, if they are free, we can take out. This will help us to expose the coronoid process. Once you see the coronoid process, then it needs fixation in the form of screw. If it's a larger fragment, they recommend to use plates, but then it's very difficult to use plate from lateral aspect. You need to go back anterior. Additionally, if the fragments are small, then you can take a bite and pull that coronoid fragment and tie it over the olecranon surface, which we'll see in the case. Radial head is to be fixed, as we are discussing this in young patient. In old patient, we can replace that. And repair of the lateral ulnar collateral ligament is very essential to make the elbow stable. Whether to repair or reconstruct medial collateral, as it depends on the medial stability. If we can't do that for whatever reasons, then we can use external brace. So this is one case, representative case. Dislocated elbow, comminuted radial head, see the ecchymosis. These are the after reduction, and this is after fixation. This is what I was talking about. Taking a bite from the coronoid, pulling with the help of fiber wire, pulling it through the dorsal surface of the olecranon and tying it over an endo button, and fixing the radial head with the help of a mini fragment screw, and then repairing the lateral ulnar collateral ligament. So this is the standard protocol what they have used. This patient didn't need an adjuvant hinged external fixator or a brace, as elbow was stable. And if elbow is stable, we should start early elbow mobilization. You should just see 2 months functional recovery. He has 30 degrees of flexion as of now, but with time he should get good elbow motion. So to summarize, elbow is a very important and complex joint. An understanding of the complex bony and soft tissue anatomy of the elbow, soft tissue stabilizer, and the adjacent neurovascular structures is imperative. In addition to X-rays, CT is very valuable in understanding the fracture geometry and in further planning of the elbow injury. Every different fracture pattern needs individualized planning and surgical execution. If recommended treatment protocols are followed, good to excellent functional outcome with a painless, stable, and mobile joint can be expected. Thank you.
Thank you, sir. Crispier as always. Can you unshare your screen now?
Shall I stop sharing the screen?
Yes, yes, please. Any questions for Sanjay sir from rest of the panelists?
Sir, there is a question for sir from on the board.
Okay. Am
Sanjay
I audible,
sir,
Tejas? Am I audible?
Yes, sir, you're audible.
Yeah.
Sir, they are asking, you have not shown any, role of external fixator in elbow trauma. So, what is your experience of using an external fixator? When do you use it, or do you use it intraoperatively for any comminuted injuries?
Tejas, good question, but I have not shown it because I have not used it. So something I have presented only those cases which I am doing or I have done it before. Yes, certainly there is a good role of external fixator in good hands, but my understanding and my experience in using either monoplanar or ring fixator in elbow injuries is, I would say I have no experience rather than saying limited experience. But certainly there is role, Tejas, in good hands.
Right, sir. So the question was asked by from on the panel, not by me.
No, that's fine. This is so. This is what I do. That is what I have presented. Rather than making it theoretical, I thought let us make it a bit practical, so that whatever ortho colleagues they are listening this, so we will get relevant questions, and I would be in a better position to answer the same.
Sure, sir. Thank you.
Tejas, just to add to it, like there are some distinct situations where, in spite doing everything like fixing coronoid, fixing radial head, and then fixing the lateral and medial side comes at the end. But many of the times, soft tissue is so much damaged that they tend to have some residual instability at the end of the surgery. And those are the indications where you will think of putting an additional stabilization externally in the form of either a hinge elbow fixator, which will allow you to mobilize them immediate post-op, or at times, like if you're not comfortable putting those hinged ones, you will be putting a static fixator also. So that will serve other purpose of like keeping your joint in little distraction so as to minimize the contractures and all. There are different concepts of that. But those are very rare situations now because our open surgeries, open repairs are quite enhanced and techniques are well advanced. So hardly we require those now, fixators.
Sanjay,
But we have like Milind sir with us, who is who can enlighten us in a much better way about the fixator use in such a complex elbow injuries. Milind
one
sir.
moment, Sanjay, if I.
Yeah.
Tejas, during early days of my practice, when I was very much terrified with the terrible triad, I used to refer these patients to other centers, either locally, 1 or 2 cases, and few cases, 1 or 2 at Pune and some at Nagpur. And in few cases, they came to us for follow-up, and medial job was done. And whatever medial job, surgical interventions in the form of repair, reconstruction I have seen, I'm yet to come across a happy patient.
Okay.
So I haven't seen someone wherein they have done some medial reconstruction or repair and patient is having painless, stable and mobile elbow. I haven't seen that.
Just the medial job, you mean to say?
No. In addition to whatever we have described, the way we do it, in addition, some people, they do it, no? Because after doing 3 jobs, coronoid, radial head and lateral ulnar collateral ligament repair, they say now to assess the one more fine point I would like to add here, that they say while repairing lateral ulnar collateral ligament, if there is injury to this medial collateral structures, then we are supposed to repair lateral ulnar collateral ligament in full supination. If the medial collateral ligaments are torn, we need to repair it in supination. If they're intact, we need to repair lateral ulnar collateral ligament in pronation. This is just one point. This is the recommendation.
This is something called as Fonzi's thumb rule, actually, for the immobilization of the elbow instabilities in a conservative manner, also for simple dislocations or after repairs also. So Fonzi's thumb rule says, like, if you can see, a lifted thumb, you will move to the side of intact or a stabilized side. Like if there is a MCL you have repaired, LCL is taken care of or LCL is uninjured, you will immobilize your forearm in a supination.
Yeah.
Okay. And for like this, if there is a LCL issue, you will put it in a pronation, something like that.
But the only difference is position of the forearm while repairing the lateral ulnar collateral ligament. So this is the only addition. If medial structures are injured, to repair it in supine position. If they are not injured, then repair it in forearm in prone position. This is the recommendation one.
Okay.
Just to add on.
Great.
Thank you very much. Thank you, Tejas. Thank you, Sanjay.
Milind sir, you want to add something about the fixators?
Well, there is a role for either it's what's known as the Compass Fixator. That's you can set the elbow center of rotation, either with a complex and sophisticated mechanism called as the compass hinge, or you can do it simply with the help of a wire that goes through the transcondylar axis and then set hinges and then do a fixation in the humerus and in the proximal ulna to protect whatever repairs that you have done and to permit active but controlled and stabilized range of motion for a short duration of 6 weeks. That role is there. I have used it in the past. I have used it along with minimal internal fixation when the wound doesn't permit And yes, even the literature supports the role of external fixation in special circumstances.
Okay, sir. Thank you.
Sanjay sir,
Yeah.
there is a question from Amit Zadav. He
Yeah.
says that what is the implant of choice in compound distal intra-articular humerus fractures TY condyle?
Compound distal intra-articular humerus. I have shown one case wherein even though it was compound, but it was a clean injury. Nothing special about distal humerus, but certainly if you are not sure about contamination, you should use as less metal as possible. But again, you need a stable joint. So if your wound is clean, the way we did, we can comfortably use plate. It's a very vascular joint, so after proper debridement and with no contamination, we can certainly use plates. If it's contaminated, then maybe just multiple wires and screws or external fixator, I would say. It all depends on degree of contamination.
Okay.
Yeah, so I think that would be a circumstance where you can do minimal internal fixation and combine that with a protective external fixation.
Right, sir. Right, sir.
So my screen is getting seen now?
Yeah.
Yes, sir. Yes.
Yeah.
Thank
So
you,
the
Sanjay.
case which I posted, yeah, no, sir. Here it is for you. The case which I posted in the introduction for this topic was this: middle-aged man with this distal radial fracture, which was compound. Sorry. The radial shaft was coming out.
Hello.
Then the distal ulnar fracture and the elbow dislocation. There are no fractures, bony injury at the elbow per se. So how would you classify it, sir? Is it a simple elbow dislocation, or you will label it as a complex? Sanju, sir.
Dislocation.
Regional bony injuries, would
Yes.
they classify as a complex injury to the elbow?
Certainly, Sanjay. Dislocations per se are complex injuries. First of all, there is dislocation. It means there is soft tissue disruption at the elbow, significant soft tissue disruption, and which makes it complex. So certainly, it's a major injury. I do not know whether there is some classification which is applicable for the elbow dislocation along with fracture of the distal fracture of radius and ulna, something what we use for say either Galizzi or Monteggia. I won't be able to classify this. How to treat it? Certainly, we need to reduce the elbow joint in emergency room. They say repetitive attempts of reduction of the elbow should not be made in emergency room. And once the elbow is reduced, we proceed with treatment of the distal part of the forearm after getting proper X-rays, and then we can plan that. It's a compound injury. We can plan it accordingly.
Right.
Right.
So much as you said, I dealt with it. After dealing with the compound radial wound and the fixations down below, what I found was like elbow was again quite unstable, and the reason is very much obviously seen over here. The whole lateral complex, LCL as well as the common extensor origin, was avulsed in a single piece. So that was the reason for a bad posterolateral instability there, which I needed to stabilize, repair it with the transosseous sutures. Was I right doing that?
Certainly, because as you said, once you have reduced it and you found it was unstable, then the wise thing you did that you opened it rather than making further attempts of close reduction, traumatizing already traumatized soft tissue, and we may add on to some, suppose coronoid is intact, and if you are doing repetitive attempts, you may get it fractured and you may add on to the instability. So you did good job.
Right.
At least decision wise, at least I would say. And
yes.
Great.
Right. So that is how it was immediate post-op. And then at the 3 months, here we can see there was like the tiny calcifications getting seen at the medial side also. So in retrospect, I can tell like that was a reason for a gross instability of the joint over there. It usually happens in combination, but like taking care of the lateral side, like posterolateral instability is the one which is quite notorious. So taking care of the lateral avulsions or lateral soft tissue repair most of the time suffices and joint gets stabilized. So here I didn't touch on the medial side, and medial injury was noticed or can be guessed after looking at this exam. So he did well at the end.
Excellent. A picture perfect job. Absolutely. And have you added indomethacin in this patient? Because I always add indomethacin 75 milligram at least for 3 weeks in all cases of comminuted complex.
Yes. We do give that as a prophylaxis for the heterotopic ossification, elbow being one joint which is quite notorious for that occurrence. Moving to
early
the next
mobilization
case.
always helps us
Yes.
not only just for stiffness, but I feel even from to get heterotopic ossification.
Right. Moving to the next case, this young boy again, 22 years old, comes to me with the X-rays taken outside and this 3D CT even. You said like 3D CT is must always. So he had gotten 3D CT also for me. So looking at it, there doesn't seem to be a columnar fractures per se, but an articular part, the complex articular fracture in a sagittal plane. Right? So how to go about it? To fix it, X-ray looks little congruous. Can I think of conserving it?
You need to assess elbow stability. If like
no,
here
this is stable elbow, sir. This is stable elbow.
Stable elbow.
Partial articular fractures on anterior part, trochlea and the this capitulum. And it is impacted. It comes to me on day 3.
If there is articular step, if you expect, because you have got a CT, if you feel that there is articular step of more than 2 millimeter, you should fix it. Certainly fixation has the advantage of early mobilization, I would say. If you are still in doubt, you can take patient in theater, and depending on the pain tolerance, either without anesthesia or under anesthesia, you see the elbow stability, assess the medial structures also. Certainly this seems to be a stable injury, only we are dealing with capitulum with or without trochlea. And in this case, if there is articular step, any visible articular step on CT and X-ray, and patient is coming to us within say 5 to 7 days, I would fix it.
Right. This being purely articular and devoid of any soft tissue attachments, dealing with these fractures, does it have any inherent risk of any particular complication you can think
vascular
of?
necrosis.
Yes. So
Provided,
we have to prognosticate.
Yes.
Right. So that would be a part of our counseling with the patient?
All the time.
Right. So for this patient, like as I said, these were like impacted fractures. Lateral condyle was little rotated out, and that was the CT step was getting seen on the CT was of that fragment only. Gently, I pried it open those impacted fragment and brought to the near anatomical restoration. There was little bone loss at the posterior aspect of the lateral condyle, but overall reduction was good, and stabilize it with almost 3-4 headless screws. And this is how it was. Some cancellous bone appearing at the anterior aspect was just the part of the comminution over there, which I missed on taking it out. But overall, it was a stable elbow. The medial plate was in addition added for the medial column stabilization.
Post-operatively, like, sorry to say this, but you are a better judge and you have seen the patient and you operated. So post-op, it seems to be overkill sort of picture, to be very authentic and honest, I would say.
But you think like this is overkill?
Because pre-operatively, as you have shown, it seems to be innocuous injury, it's a simple injury. So
right.
But intraoperatively, you have seen that. So if I am a surgeon somewhere else, and if I see this X-ray and I don't talk to the primary surgeon, I would say कि काफी सारा ना
implant डाला है. Yeah. So same thing was like after putting headless screw, when I noticed that articular block that we create in such surgeries is kind of like the medial condyle was again undisplaced fracture over there, and I thought like it needs added stabilization, and that's why the medial plate was put. But it certainly extended the invasion over there, which I had to pay price for. And at 11 months, what I can see is like there was a lot of hypertrophic leaping at the orecranon tip and here and there, which gave him a lot of stiffness. He was just having just jog of a 20-30 degree flexion possible. So at 14 months of postoperative electively, I removed those implants, and this is after the implant removal. And this is after at the time of implant removal itself, utilizing the same posterior approach. I went on both bilateral, collateral dissection, removing those hypertrophied leaves, and all the adhesions were cleared off. And this is after a year post-op, post-implant removal and ortholysis. This is the flexion he has got. And this is the coronal picture near full extension. I had not sweated a lot throughout the course, but at this one point, like yesterday only, I had called him just to put this current status, and the boy he innocuously questions me, indicating at his right elbow, and asks me, "Sir, iske liye kya kuch kar sakte hain kya?" So now I included that of the right elbow injury again, like it was a childhood trauma, query, Montegia, neglected Montegia. He had some prominence over there, which was abetting and restricting his elbow motion. So in a second stage, his elbow, his radial head was excised. He's having good function there, just a trouble with valgus deformity and some difficulty in doing some heavy jobs. Or while driving the bike also, riding the bike, he feels fatigued with his right elbow quite often.
Just see whether he has any tardy ulnar nerve, if you like.
No.
Or at least inform him that he just need to watch for that.
Yeah, he's like he was child when all these things happened. Now he's grown up. He's 24 years now almost. So is there any what further? Is it something to offer him, or
no. Already,
just
don't touch. Already you have burnt your finger, and luckily he is happy patient at the end of 1 year. So
he's very happy with his left side. That's why he's asking, sir, his left. Right ke liye kuch karo.
You were lucky, na? Even on left side you are lucky. So leave him. Let him be happy.
Yes.
Right. Okay. Thank you. Very interesting cases. Thank you very much.
Yeah. So moving on to the next talk, where like youth is gone, strengths are gone, one tends to get weaker by the old age, and so is true for the bone quality. What exactly, how do they behave, these elbow injuries in the old age? Let's listen from one of the senior orthosurgeon from Akola, who happens to be our Akola IMA president also, Dr. Mahendra Kale sir. I'll request him to give his talk. Kale sir. Please share your screen, sir.
Good evening all. Geriatric elbow injuries and concern. Just a minute. The geriatric fractures are synonymous with the fragility fractures. These fractures occur during activity that would not normally injure young healthy bone, like fall from the standing height or less. Fragility fractures are a large and growing health issue. 1 in 2 men and 1 in 4 men over 50 years of age will suffer a fracture in their remaining lifetime. A prior fracture increases the risk of new fracture by 2 to 5-fold. Osteoporosis is a systemic skeletal disease characterized by low bone density, microarchitectural deterioration of the bone tissue, enhanced bone fragility, and increased risk of fracture. while we treat the fragility fractures, the optimal care of fragility fracture patient is very important. The patient with the fragility fractures are associated with lot of comorbidities, and the priority goes to keep the patient alive, for which we need acute medical management. Fracture fixation itself is a surgical challenge, and objective is to keep the patient mobile. For that, we need multidisciplinary rehabilitation, and keeping the patient from returning to your fracture unit again, we will have to treat osteoporosis itself and secondary prevention of the refracture. Now, these elderly patients with fragility fractures, there are complexities like they are associated with comorbidities. These comorbidities may include compromised heart function, compromised renal function, COPD, diabetes mellitus, delirium and dementia, pseudo-obstructions, impaired metabolic response to injury like hyponatremia. And these patients are also associated with polypharmacy. They are many times on the anticoagulants and neurotropics. And these points needs to be considered while treating these geriatric fractures. It is difficult judgment to balance between medical optimization and prompt surgery. We should give extra attention to such elderly and osteoporotic patient and prepare them for surgery. Close supervision by physician is very much needed. Medical backup from the different specialties may be needed, like anesthesia, cardiology, respiratory medicine, and general surgery, etc. Geriatric fracture around elbow may be treated conservatively or by surgical approach. Surgical approach is for synthesis and arthroplasty. Now, conservative treatment, as we have seen in back few years before, but now it is reserved for undisplaced fracture, and that too in low demanding patient. Non-union rate is as high as 47% in conservative treatment, while malunion is as high as 70%. Conservative treatment is associated with low Mayo elbow performance score and low disability arm, shoulder, and hand score or DASH score. Surgical management may be osteosynthesis or osteoporosis. The anatomical joint reconstruction and stable fixation of intra-articular and comminuted fracture remain difficult to achieve, and the operation for displaced intra-articular distal humerus fracture is particularly challenging. Now, objective of osteosynthesis: anatomic reduction of the fracture, reconstruction of the articular surface if needed, stability and rigidity of the fixation, early and appropriate rehabilitation. Osteosynthesis in geriatric fractures may be done by locking plate, pins and plates, reconstruction plate, double tension band wiring principle. Open reduction and internal fixation remains the gold standard in osteosynthesis in geriatric fractures. Now, in osteosynthesis by plate, 2 points are very important. One, anatomic reconstruction of the intercondylar fracture and use of the transverse cannulated screw. It allows improvement of fracture type C to type A. And second point, the plate should be made to fit the shape of the distal humerus, and screw should be tightened one at a time as far as possible. Biomechanically, double plates have advantage over single plate. Two plates may be configured in parallel or 180 degree, perpendicular or 90 degree, or in a Y configuration that is dorsal plates. Plate configuration, now here you can see that this is 90 degree configuration with posterolateral and medial plate. Posterolateral it is posteriorly. Here it is 90 degree with posteromedial plate and a lateral columnar plate, and this is parallel or 180 degree configuration of the plate, and this is a Y plate or Y configuration. Now in osteosynthesis by plating, open reduction and internal fixation is a treatment of choice. Biomechanically, double plates have advantage over single plate. Biomechanical strength of plate configuration, 180 degree or parallel plate configuration is most rigid biomechanically, followed by 90 degree or perpendicular configuration, followed by dorsal or Y-shaped configuration. But no significant difference in rigidity between three fracture fixation configuration in case of no gap in between the bone fragment and in presence of additional distal screw. Clinical outcome by plating may be improved by minimal invasive exposure, indirect reduction, use of locking plate, and identify mechanical peak torque to decrease the screw failure rate. Locking plate lead to greater stability and higher loads to the failure than traditional plate. New locking plate, when combined with surgical tactics that adhere to principle of biological fracture repair, can achieve excellent result. Locking plate design has improved surgeon ability to achieve stable fixation in osteoporotic bone. This combined with anatomical plate design have led to successful repair of juxta-articular fractures. Although these plates allow less invasive approach, which may be benefit soft tissue healing, stable reduction must be achieved to avoid complication of fracture fixation. This is a case of comminuted geriatric fracture lower end humerus where 90 degree plate configuration was used to fix the fracture, and here is the low intra-articular fracture which was used by 180 degree configuration of two plates. Now another mode of fixation which is very useful is double tension band wiring. It is useful in far distal fractures where there is no bone loss in the fragment. It has advantage of early mobilization, which can be attributed to rigid fixation provided by the tension band. The amount of periosteal steeping and soft tissue damage is significantly less than plate fixation. It is simple procedure and it has less surgical time. It is cost effective when compared to cost of plates. Tourniquet time can be minimized. Because of rigidity and stability achieved in this technique, and because the tension band wiring technique acts as a dynamic mode when muscle contracts, we can mobilize the patient very early. In fractures in osteoporotic bone where large implant can have shattering effect and screw may loosen out, this technique gives good hold without fear of loosening with minimal implant. This is a double tension band wiring technique. How it is used: 2K wires on each side with tension band on each side. Now, another fracture around elbow is fracture proximal ulna. Fracture of proximal ulna range from simple olecranon fracture to complex Monteggia fracture. It is of utmost importance to reconstruct a stable manner the hook of olecranon and lateral column as represented by radial head. The post-operative rehabilitation program should involve active elbow motion exercise without limitation as early as possible following surgery to avoid joint stiffness. Now, fracture proximal ulna, there are different treatment options available Popular of them are tension band wiring, intramedullary screw fixation, and plate fixation. The management of olecranon fracture primarily comprises tension band wiring in a simple fracture as valid treatment option. But modern plate techniques, especially comminuted or osteoporotic fracture type, can hold and maintain the reduction more anatomically and thus reduce failure and potential implant-related soft tissue irritation. In fracture proximal ulna, tension band wiring, even today, this technique represents a working procedure with good clinical outcome if it is accurately indicated for stable oblique fracture. However, its biomechanical limitation become evident in comminuted fracture. In plate osteosynthesis, the management of comminuted and unstable fracture using a locking compression plate via dorsal approach has been well established in recent years. Offloading tricep suture. In highly comminuted osteoporotic bone in elderly, the use of offloading tricep suture is shown as a good treatment option to neutralize the distraction forces caused by extensor mechanism and therefore to decrease the risk of fixation failure with loss of reduction and displacement of the fracture fragment. But we need to keep it in mind that offloading tricep suture technique is an augment to plate fixation in osteoporotic ulna shown in this figure. Radial head fractures. Osteoporotic or fragility radial head fracture. Radial head resection remains a good option when radial head fracture occurs in an elderly patient, taking into account the influence of poor bone quality and comorbidities on the outcome. Radial head replacement is associated with high complication rate in comparison to with radial head resection. What I am talking about is elderly osteoporotic patient. Now, radial head excision is recommended in fracture without associated instabilities. Now, treating the geriatric fracture or osteoporotic fractures, there is a definitive role of anti-osteoporotic treatment. Anti-osteoporotic medication are often used concurrently to treat a patient's fragility fractures and underlying osteoporosis. The data suggests that these medications may enhance bone healing. Vitamin D and its analog are essential for the mineralization of callus and may also play a role in callus formation, the remodeling that enhance the biomechanical strength. Although bisphosphonate and denosumab delay the callus remodeling, they increase the callus volume and result in unaltered biomechanical properties. Calcitonin increases cartilage formation and callus maturation, resulting in improved biomechanical properties. Clinical data with parathyroid hormones have demonstrated enhanced healing in distal radius and pelvic fracture in case of geriatric or osteoporotic fracture. These are the medications or drugs which are used: bisphosphonate, calcitonin, estrogen progesterone, raloxifene, parathyroid hormone, and active vitamin D metabolites, strontium ranelate. It is recommended calcium and vitamin D for all women at risk for osteoporosis. Now, take home message: open reduction internal fixation is considered as a gold standard for treatment of geriatric fractures around elbow. Total elbow arthroplasty has proven itself as an adequate treatment option in elderly patients with osteoporosis. Less invasive approaches like tricep reflecting and tricep sparing approach have low complication rate and good overview of articular surface. High complication rate of internal fixation in the patient with osteoporosis highlights need of supplemental systemic anti-osteoporotic treatment. Thank you.
Thank you, sir. Please unshare your screen.
Just a minute.
Any questions for Kyle sir from the rest of the panelists? Any questions for sir? So he has nicely covered everything. Even I will skip whatever the case I had, relevant case I had to show. Like in summary, he was talking something about getting adapted to like avoiding the olecranon osteotomy, which is quite a workhorse for like most of our posterior elbow exposures. But like for the old age, as we know, like olecranon fixation most of the time remains the reason for any future troubles and remains the reason for implant removals quite often. So the general recommendation is to avoid on olecranon osteotomy and to switch to the something this tricep reflecting and something called like this strap approach and all. So quickly I'll move to the, as we are listening from all these speakers and we have experienced to the cases, like elbow is one joint which is quite prone for developing the complications in spite of no matter like what, how good, how emergent you treat them or like how good you treat them conservatively or surgically. There is some inherent risk of the complications involved. So let's listen to like how to deal with those healing complications of the elbow injuries from we are like fortunate to have with us this world-renowned faculty, limb reconstructive surgeon in the form of Dr. Milind Chaudhary sir, who hails from our town itself. And let's listen to his experiences. Over to you, sir.
Thank you very much, Sanjay, for your very kind introduction. This is a very interesting webinar you've put together. It's a very comprehensive subject and it's very difficult to do justice to the entirety of the subject matter. So considering that brevity is the soul of wit, I would like to deal with the subject given to me by you and by IMA Akola with an element of brevity, and I would touch upon it to keep it interesting. After all, the elbow is a very interesting topic and there's much that we can learn on a regular basis in the treatment of acute trauma. For example, one of the things that I didn't see being touched upon was the role of what is known as the skinny wire technique for fixation of the TY condylar fractures, which I have been using for the last 2 years now. It's extremely thin wires, 1.25 mm at the periphery of the, the trochlea or the capitulum, and which are then bent and fixed under a plate. So instead of having screws go down from the plate, etc. There are exposures of the elbow, for example, which is known as the surgical dislocation of the elbow, which is analogous to the surgical dislocation of the hip, in which we do an osteotomy of the lateral epicondyle, and it gives us a very wide exposure of the anterior aspect of the elbow. But I will stick to my brief and speak to you very briefly about 2 aspects of reconstruction after elbow trauma. And this is going to be a little external fixator centric. I do use internal fixation very, very widely, but just for completing the topic, I would start off with Cubitus Virus, which is a commonest malunion following a supracondylar fracture of the humerus in children. It's also known as the gunstock deformity. Now, as we all know, this is a purely cosmetic deformity, as in this young man, and the appearance is a little disconcerting. It usually causes no functional limitation whatsoever, as we are fully aware. but it's a very disconcerting deformity and also is not acceptable for police bharti and army bharti. So if it is a cosmetic deformity, then does the science that we have, that we know, the French osteotomy and the corrective osteotomies, however old the osteotomies may be or however modern they may be, by taking an incision and by putting in a plate, we are adding a cosmetic scar. And the other thing that happens is if we do not translate, even if we just do a closing wedge osteotomy, it creates a bump. So what we have been doing is the Ilizarov external fixator, which is minimally invasive, has very small pinpoint scars, and it takes away the possibility of this lateral bump that you can see over here. So this is this young lad pre-operatively, and these are his measurements. So normally we have a carrying angle, and when the carrying angle reduces, it really looks ungainly, and wearing half shirts is very, very, uncomfortable for the looks. So this is how we do this surgery. Instead of taking an incision and creating a scar, which is typically on the outer side, because you don't want to go medially and go near the ulnar nerve, you go laterally. So when the scar is lateral, it's very visible when you wear a half shirt or a t-shirt. So what we do is we use the Ilizarov external fixator, which is minimally invasive. We use half pins and wires sometimes, and the bone is cut through a tiny incision. So all in all, we end up having 5 scars, which are about 5 to 6 millimeters long. And the essential element is the angulation translation osteotomy. If you focus over here, what you can see is there is a translation of the distal fragment. The edge of the distal fragment is translated medially so that the center of the proximal and the distal fragment line up. If you don't translate the distal fragment, there is an ungainly or an ugly bump which is present laterally, and it takes away from the from the very need of the cosmetic surgery. So this is how it is. It's medially translated. The Ilizarov fixator allows us to give sustained compression. There is good elbow range of motion, and the patient heals up rather well, like so. And here he is with a good range of motion and full extension and full flexion without problems. And the scars are minimally or very barely visible. So if it is a cosmetic deformity, we should treat it in such a way that it does not lead to cosmetics, bad, ugly scars. Similarly, a young child like this, the deformity, and here again, very thin, tapered, titanium half pins are used. It's a minimal fixator. It doesn't block the movements of the shoulder or the elbow. The pins are inserted mostly from the lateral side. It's a percutaneous osteotomy. And again, note the medial translation of the distal fragment. And here he is after remodeling and complete correction and full range of motion that he has and full correction of his cosmetic deformity. And slightly in a more expanded state, another young man, the son of an serving army man, you can see the cosmetic bump, which is very ugly. Now, if we do not translate the distal fragment medially, if we just do a closing wedge osteotomy known as the French osteotomy, it will create a further bump. There's something else that was described called the pentalateral osteotomy, but it needed a big scar. And then these days, there's lots of hype about the patient-specific cutting guides, which I don't think is really all that necessary at all. So here is this child. These are the steps in the surgery. These 2 half pins are inserted, titanium half pins laterally. You can palpate the radial nerve and make sure that here the radial nerve is passing like this. Both these pins are inserted anterior to the course of the radial nerve. This one pin has been inserted from the medial epicondyle, okay, by very carefully making sure that you are from anteromedial to slightly posterolateral, and then this posterolateral to anteromedial. And here is the patient is placed prone. The rings are attached, and you can see this, the outlines of the osteotomy are created. This is a dome osteotomy, okay. And this video should show the steps. This is how we translate with a small incision, with the help of the osteotome, which is turned, we achieve the necessary medial translation by rotating the osteotome. until we are happy, and we check it under the C-arm, and we make sure that the required translation is achieved. And so here it is. This is the X-ray showing the osteotomy in place, rotating the distal fragment till it has gone medially. And again over here, then the multiplane hinges are attached. This medial translation is the key to preventing the unsightly bump. And so here is the child in the fixator. You can see it's a 5/8 ring. It's open over here. He can flex his elbow nicely. He can move his shoulders. We can compress it. He's quite comfortable in the fixator. And that helps him to achieve, the necessary goals. That is retained function and a good amount of cosmesis. So here he is with his, the function. And you can see that his deformity has been corrected and the scars are not visible. They're barely visible. And that's the key to remember. So Cubitus virus, or the gunstock deformity, as we all learn, is the very first complication of the common fracture of supracondylar humerus. And this is the way we've been treating for the last 30 years with very gratifying results. So now let's come to the second part, the second brief part of my talk, that is the treatment of juxta-articular non-unions. Now, there are many things that I have been doing. For example, the treatment of lateral condyle non-unions, but unfortunately, I apologize, I could not find the X-rays. I have done a similar supracondylar osteotomy to offload the lateral condylar non-union. We have been performing lateral ulnar collateral ligament reconstructions. But I will stick to the non-unions part, especially the infected non-unions. A few cases like this. This lady came to me from Mumbai with a lot of infection. Her CRP was raised. She was operated several times. Multiple implants had failed. And so the bone is soft. You can see it's pockmarked with all these screws. So when in doubt and when as a last resort, the Elizarov fixator can work very well. Now watch here. You can see that distally in the forearm, I have not fixed her, but I have used a cast which is attached to the ring. These are carbon fiber rings. These are half pins at the proximal level, and distally, these are wires that go from medial and lateral sides and horizontally in the plane of the humerus, and they give great fixation. And we are able to give compression like this. You can see the bone is gradually healing up. You can add half pins if needed. And here she is with a union of her fracture. In complicated situations, such as this very bad gap non-union at the elbow. Now, this gentleman it was difficult to assess the range of motion in the native elbow, and all his movement was at the flail juxta-articular non-union. And he was advised, that you may lose all motion, or if you're lucky, if the non-union heals up, then later on you may develop a little functional range of motion. And he agreed to this. He had an ulnar nerve, injury, which was partially recovering. He said, "Aap meri haddi juda do, jo baki hoga dekha jayega." Now, because of the nature of the soft tissues, you cannot go down and put in a plate and screws. There's very little hold. And if you just go across and make a U-shaped plate and fix the humerus to the ulna, you're going to definitely lose whatever hope there is of regaining later elbow range of motion. Hence, we chose to use the Elizarov fixator, the trusted Elizarov fixator. You can see here he's got augmented fixation in the upper ulna and the distal ulna with carbon fiber rings. The medial side is kept open so that he is able to keep the arm close to the chest. If your arm perpetually stays away, then the fixator is uncomfortable. So a lot of the things about the fixator are practical and common sense. If you can cater to the common difficulties the patients have, they are able to tolerate the fixator quite well. He is in his late 50s. He tolerated the fixator well. We did add bone graft, and he went on to heal. I have called him for a follow-up since you announced this webinar, and I would like to see how much range of motion he has regained in his elbow. Or later on, as some of you have said, we can perform an arthrolysis. We can do an anterior capsulotomy and resect some of the osteophytes anteriorly and posteriorly to give him a bit of range of motion. And I would finally like to end with this case that I did 25 years ago. This lady had an amputation of the arm in which replantation was done. The neurovascular structures were replanted. A lot of flaps were performed, and she was sent to me to treat the recalcitrant non-union of the humerus. As you know, in replantations and microvascular surgery, the bone gets the least priority. And so that's what happened. I'm sorry, this is a very old case, but you can see over here that the non-union, this is the non-union in the lower humerus, and this has not, healed. So considering the status of her soft tissues, which are very deficient, we chose to use the Elizaro. We can see the wires fixing the distal fragment like this. And here she is. She went on to heal well with this. And this is the kind of function she had. So the microsurgeon did a great job 25 years ago. And thereafter, we managed to give her a stable and a mobile elbow. And I really thank you for your attention. I congratulate Dr. Sanjay and team IMA Akola for conducting this very exhaustive webinar. And I would be happy to answer any questions if you have them.
Thank you, sir. Thank you. Any questions for Milind, sir? So please unshare yourself.
Is it pause share or is it
Stop share, yeah.
stop share?
Yes. So any questions for sir now? He has shown cases like which we hardly get to see in such a complexity. But that's his routine. Even I had placed 2 of the cases over there, but I will not spend my time in that. I'll quickly ask about this case, sir. A young man, road traffic accident, bad road traffic accident, almost a grade 3 B or C injury he had, and he's been managed elsewhere with these provisional fixations, I believe. Elbow, there is a complete articular bone loss, and the elbow is possibly provisionally splinted, utilizing these intramedullary nails with the both bone fractures down below, which are, again, it seems if they are failing to heal. He was like almost 6 months down the line of his earlier surgery. So should I believe that this will last long, or this is not going to last? This is not
so
going to be a permanent
what's his
solution.
neurovascular status?
He is having functional hand.
Yeah, of course not.
Luckily.
You're right. Okay.
So no, he will not accept the amputation. I can guess about that, like what you are pointing at. Are you aiming at amputation?
No, not at all. Not at all. An elbow fusion would probably be the only way to give him a stable upper extremity with which his hand, shoulder and hand can function. Though it's not, it's a little difficult to manage things, but under the circumstances, there's nothing else that one can do. And achieving a stable fusion, even with poor soft tissues, is possible with the Elizaro. If the soft tissues are good, you can use in a plate that spans the posterior humerus and the ulna and bone graft. I'm sure it's not that difficult. But if the soft tissues are not very forgiving, then you can use the Elizaro fixator and give him nice compression, add some bone grafts, roughen up the surfaces of the olecranon fossa and whatever is remaining of the distal humerus, and he should do reasonably well.
You will think of a transport, or you will think of a shortening of the docking, acute docking of the limb?
Well, if you are really worried, I don't know how much loss is there because the X-rays are small. But in the fixator, we can add a little humerus lengthening if he's already lost a lot of humeral length, because we are going to fuse it in about 90 degrees. And the reach of the arm is going to depend on both the length of the humerus as well as the forearm. The forearm is good. If you're worried about the shortening, we can proximally lengthen, but rather than a transport, we would get the things to dock first and then simultaneously lengthen at an upper level. 15% of the shortening of the arm is well tolerated. That's typically 3 to 4 centimeters, and one need not bother and add complexity to the problem.
Right. So thank you for that opinion, sir. So here we come to the one last talk. like it's not possible to reconstruct. Like sir is master in reconstructing each and every, like whatever difficult situations he had shown. But at times, like there would be a situation where like replacing the articular segment would be easier than reconstructing. So are there any such specific situations of the elbow replacement, and where we stand today in offering that option? I'll invite Dr. Achin Murarka, who is an orthoplasty surgeon trained from New York. Over to you, Achin.
Thank you, Sanjay sir, for giving me this opportunity to present the work.
Share your screen.
So is my screen visible?
Yes.
So I would like to thank you and IMA. Very good evening to everyone. I think elbow replacement should be the last resort when anything is not working, and it should never be considered as the first choice for the treatment. So it is a very rarely performed surgery, and let's brush up with the things and whatever what is available currently. Certain new things are also coming up. So to start with, the elbow is a 1 second, please.
Achin, start your slideshow.
Yes, sir, I have started. Is it visible?
No. Do one thing, unshare first and then reshare, or like keep working in the same window.
Okay, should I stop share now?
Yeah, and reshare again.
Yeah, is it okay now?
Slideshow now.
Is it visible, sir?
Slideshow is not running. You can continue with the same grid, not an issue.
Okay, this is okay.
Yeah.
So the elbow is a complex joint consisting of ulnar-humeral, radiocapitular, and proximal radio-ulnar joints. Flexion and extension, along with forearm rotation, are its main function. Loading of the elbow is relatively low for many activities of daily living. So pathology of the lower extremities generally result in reduced mobility of the patient. In upper extremity, however, pathology restricts the patient from performing simple activities of daily life. In this situation, the problem cannot be managed by braces like wheelchairs or crutches, which are very essential in lower limb. However, forces transmitted across the elbow can be high for some activities, exceeding 3 times the body weight, thereby challenging the longevity of total elbow replacement. So the aim is to achieve painless and stable motion for activities of daily living, vocations and avocations. The primary indications are osteoarthritis, post-traumatic arthritis, rheumatoid arthritis, comminuted elbow fractures, non-unions, dysfunctional instability, post-traumatic deformities, tumor. When the incidence of arthroplasty continues to rise for acute trauma and post-traumatic sequel, it has been reducing for rheumatoid arthritis because of effective management of medical management. So the absolute contraindication is an active infection. Very, you can say non-functional hand and wrist, which often occurs in post-traumatic sequels of upper limb traumas. Earlier, it used to be an absolute, but these days it can be considered. Severe elbow destruction after a post-operative joint infection, such as one associated with primary arthroplasty or ORIF, was one considered as a strong contraindication for arthroplasty, but nowadays, with the invent of very good antibiotics, time-free period, you can go ahead with elbow arthroplasty. There are certain relative contraindications. Foci present and infection foci in other parts of the body like genitourinary, pulmonary, skin lesions, non-compliant patients affected by psychiatric diseases, alcoholic patients, and with cognitive impairment, poorly motivated patients, patients who require an elbow that can cope up with fairly high functional demands, patients with deambulatory issues or who use a wheelchair or crutches. Also, looking at the operative, if there is inadequate soft tissue coverage, adequate muscle or motor power, skeletally immature or very young patients, and a Charcot joint. So, what are we going to look into? The first is the total elbow. Second is the radial head replacement. Third is hemiarthroplasty, distal humeral replacement, capitular and radiocapitular replacements. Coming to the total elbow arthroplasty, so its use has almost doubled between 1998 and 2011 in United States, but still it is very uncommon. It is performed more often in women than in men, and is also used in relatively young patients. As compared to THR, elbow arthroplasty is performed only 1.4 patients per lakh population compared to almost 100 patients in THR. So, what are the types of total elbow arthroplasty? It can be done in three ways. The prosthesis can be linked, unlinked, or it can be convertible. So, the linked prosthesis transmits higher forces along the implant. For doing an unlinked, it requires intact ligaments and good bone stock. The convertible ones can be converted from an unlinked to linked articulation if instability is problematic without having to revise the humeral or ulnar components. They can also allow conversion from distal humeral hemiarthroplasty to total without removing the humeral stem. So, coming to the linked semi-constrained design, these are second generation linked semi-constrained design featuring a central cylindrical bearing and two sides bearing. Most frequently used device, and the implant permits 7 to 10 degrees of varus valgus movement and 7 to 10 degrees of axial rotation, reducing stress concentration on the bone cement interface. Adding an anterior flange to the humeral component also protects the bone cement interface from stress forces. However, aseptic loosening together with bushing wear is a complication. Historically, the main indication for linked TA was chronic inflammatory arthropathies in advanced stages, particularly rheumatoid, with a setting of severe joint destruction after failed medical therapy. So this is how this linked prosthesis looks. This is the humeral component, this is the ulnar component, and these both are joined together with the help of a pin. So this is after combining the parts, and this is the anterior flange which can be useful sometimes. Coming to the unlinked design, theoretically there is no mechanical connection between the humeral and ulnar components. It has advantage of near normal elbow kinetics and preservation of bone stock. Was established to overcome loosening of the hinged prosthesis. The concept and objective of unlinked TA are to share loading stress on the bone implant interface with the surrounding tissues. So this is appropriate only for patients with limited bone loss or limited deformity and good ligament function. Have low intrinsic stability and rely on soft tissue balancing. The primary stabilizers are the medial and lateral collateral ligaments, whereas the secondary stabilizers are the posterior capsule and surrounding muscles. Post-operative instability is a major complication. The survival rate reported was 87% at 5 years and 70% at 10 years. So these are the two components. This is the separate humeral component and this is the separate ulnar components. And there is a no hinge and just it sits on one another. So the main balance is provided by the soft tissues around. So in linked arthroplasty types, the pulling forces during the lifting are transferred more to the humeral component than in unlinked, since the unlinked TA requires ligament and muscles to remain stable in this situation. Coming to the convertible design, the latitude system allows surgeon to choose between a non-constraint and semi-constraint prosthesis. If the surgeon has concerns regarding collateral ligament insufficiency or implant stability, a semi-constraint hinge can be created by applying a modular component. So 2-year follow-up outcome of convertible was comparable with that in historical controls. No long-term survival data has been reported. So when you are in confusion regarding pre-operatively what should I use, then this is the ideal system to be used. So it requires you can have an intraoperative assessment, and during surgery, if if after reducing the humeral, ulnar, radial components, the one should check the stability, articular tracking, axis of rotation, and ROM, and then come to a conclusion whether this can be continued as a unlinked or linked. If the stability is not good, then the same humeral and the ulnar components can be linked together intraoperatively and converted to a linked prosthesis. Also, if previously a distal humeral hemiarthroplasty is done, so there is no need to change the humeral component. Just by adding the ulnar component, you can convert the hemi into a complete elbow replacement. So these are the parts. This is the ulnar radial head prosthesis. This is the ulnar component with a half hinge, and this is the humeral component. So this half hinge is available as a separate piece. This is after joining this piece to the hemi one, you can convert it into a total elbow. So this is how this piece fits here and completes the circle. This is the X-ray. This is a linked one, and this is not a linked one. So coming to the overall outcomes, the main problem with total elbow arthroplasty is the survival rates. So they have seen the outcomes as American shoulder and elbow score was 66.7 after surgery, and the MEPS was in RA patients was 85 and trauma patients was 84. Approximately 60% of the patients were pain-free at a follow-up 6.3 years. Weighted mean difference of flexion angle was 129, extension was 30 degrees, supination achieved was 66, and pronation was 71. Complication rate was in linked prosthesis was 9.5 and unlinked was 6.5. The Norwegian arthroplasty registry showed the survival rate at 5, 10, 15, 20 to be 92%, 81%, 71%, and 61%. The most common failure cause in short term was infection and long term was aseptic loosening by prosthetic wear. So the common complications were infection, loosening. So it was more in inflammatory patients than those with trauma-related indications. Complications were increased in patients having young age, obesity, smoking, high comorbidity. Linked arthroplasties tend to require more revisions due to polyethylene wear, and whereas unlinked prosthesis revisions were required due to instability and dislocations. So this is one of the complications showing gross resorption of the bone due to stress shielding and osteoporosis leading to fall and fracture. So what are the future challenges which we can improve the survival rates and outcomes? So the present issues mostly are aseptic loosening and infection. So the designs and choice of material can be improved. Recently, they have introduced the HA-coated stems. The third generations are good choice when pre-operative decision on linked or unlinked is not clear. Also, restoring the radiocapitular joint by inserting a radial head prosthesis is possible. So when you are using more and more elbow arthroplasties, this leads to another problem of revision arthroplasties, in which the research is very limited now. The improved overall results might also question the need of post-operative functional restrictions, because if the patient is going to work more on this is going to lead to shear distracting forces on bone implant junction and theoretical risk of implant loosening. So high demanding patients show worse overall implant survival compared to low demanding patients, but this is a theoretical perception which needs to be documented by research. Further, do we have any role of 3D printing either in creating the bone or the prosthesis? Lastly, the large implant registries is also needed. Now coming to the radial head replacement, this I think amongst the all arthroplasties being performed, radial head is the most commonly performed one. So, but why is the need for a radial head replacement since the teaching has been to excise it? So because excision causes pain, instability, proximal migration, decreased strength and osteoarthritis. These outcomes are related to critical role of radial head in force transmission and stability of the elbow. The lack of these stabilizing effects are even more relevant in presence of associated ligament or other bone injuries. So there is a long list of indications, but acutely comminuted fractures which cannot be fixed, more than 3 fragments, complex elbow injuries involving the, as we have discussed in the trauma segment, ligaments are there, coronoid fracture is there, terrible triad is there. When there is instability after radial head excision, persistent pain and instability following resections, malunions or complex elbow fractures, suspected SH loquacity. So the contraindication is again infection, and secondly in fractures that extend beyond the bicipital tuberosity due to mismatch of the rotational axis of the implant and the capitulum. In these conditions, cemented long-stem bipolar prosthesis may minimize the effect of this mismatch, even though it remains at a high risk of failure. So the level of the neck fracture is also an important consideration to be taken. So there are various types of prostheses available, like silicone. It can be either unipolar or bipolar, monoblock or modular, anatomical or non-anatomical, cemented or press fit. So these are the various prostheses. What is the goal? It is restoration of the joint stability, preservation of range of movement, and maintenance of radial length in patients with complex radial head fractures. Now, coming to the most commonly performed, I will go in a bit detail in the surgical technique of this procedure. So the benefit is it is a simple technique, simple instrumentations are there, and a solid scientific background is available to support this. The main disadvantage is it requires a press fit insertion, which is not possible always because of osteoporosis or maybe limited modularity in the systems available. So the patient is positioned supine with the arm draped free. This allows for a C-arm check and also preclude any other concomitant surgical steps to treat coronoid, proximal ulna or soft tissues. The approach is copper approach between anconeus and extensor carpi ulnaris. So exposure should be good. This is one of the primary requirements. So we have to detach the common extensor tendon 2 centimeters proximally and slightly anterior to lateral epicondyle with the release of anterior capsule. The proximal exposure increases the visualization of radial head without affecting the LCL complex. When there is associated elbow instability due to detachment of common extensor tendon or LCL, this step may not be required. So after the incision of the annular ligament and exposure of the radial neck, extensive surgical exposure of the radial head diaphysis is not usually necessary. Once the radius is visualized, you need to put 2 Homans retractor anteriorly and posteriorly so that it helps in pulling the radius out laterally so that we can get an access to the medullary cavity. So preparation of the diaphysis is very important because it can have profound consequences on longevity of the implant. If the radial head is still attached to the radial neck, and osteotomy is required, which should be planned according to the implant which you are using. Every system will have a broaching system for proper stem fit. Some systems provide angled broaches, which does not require the radius to be subluxated laterally. Now, this chart is of the biotech implant. So, what all things do we need to consider while inserting a radial head prosthesis? So, first is the length. Second is the height of the head. Third is the overall size of the radial head looking from the up, and third is the size of the stem. So I'll come to it. Most important thing is when you are calculating the radial head diameter, so it should not be from outer edge of the diameter. You should always consider the articulating portion of the radial head because if you are using a larger size, then it can lead to overstuffing. So whenever there is a doubt, it is always suggested that one should use a size smaller. The neck length can be estimated based on the amount of neck resected. If the resection approaches the tuberosity, as I told earlier, a long stem implant as an additional distance from capitular to resection should be used. So this is the implant. We have used a long stem along with the, it has a slight angle. If you see, it is not straight to accommodate the neck shaft angle for proper alignment. Now the thickness, coming to the thickness, it is very important so that it doesn't again causes overstuffing. So the landmark which we are using here is a lesser sigmoid notch. Also, the coronoid can be used as another landmark. So this is the greater sigmoid notch. Here is the lesser sigmoid notch. This is the coronoid, and here is the supinator crest. So lesser sigmoid notch, the proximal margin is the most important landmark for which will help us in knowing the position of the prosthesis. So here the lateral coronoid, it should the radial head should be in line with this, and secondly the lesser sigmoid notch, the proximal margin is an important landmark. So here we can see the radial head prosthesis is almost 3 mm below the proximal margin of the lesser sigmoid notch, which is acceptable and has shown a good long-term results. But in ideal situation, it should be 1 mm distal to the proximal margin of the lesser sigmoid notch. This is the ideal setting if we can achieve this. In this particular case, this is proximal to the margin, and this should be avoided. It can cause severe overstuffing of the radial head. So there are how to avoid overstuffing. So first point, there are 3 important points. First is the exposure should be very good regardless of the type of the surgical approach. Unless and until you are going to visualize the lesser sigmoid notch, you are going to land up in problems. And during implantation, one important thing is don't give any varus stress during the insertion. The trochlea and the ulna should match perfectly. Some pressure from distal to proximal can be helpful to guarantee a perfect matching and exclude any opening on the lateral side of the elbow due to concomitant varus stress. The lateral opening could lead to an error from the surgeon to fill the gap with the radial head component that is too long, causing overstuffing. And lastly, you can use the CM. So once you have inserted, always use a smaller, one size smaller size for a trial. And trial reduction is very important to see. And once it is inserted, you need to put the elbow in a complete range of movement from flexion to extension, and particularly the tracking is very important when the forearm is supinated. It should be sitting properly in both flexion and extension. So the repair of the lateral ulnar collateral ligament is very important, and closure is equally important as to put the prosthesis in. Now coming to the hemiarthroplasty, which is distal humeral replacement, it is very option useful in selected acute distal humeral fractures which cannot be reconstructed and non-unions. So likely require less weight restrictions than for TEA. The collateral ligaments must be repairable. I don't think this is FDA approved, and in US it is been done as an off-label surgery. So capitulotrochlear and supracondylar fractures are the indications. In patients too young for TEA, which we cannot directly perform, so this can be a salvage time-buying procedure. Again, failed ORIF, malunion, non-union, avascular necrosis of the capitulum or the trochlea. So the advantage is there is no polyethylene bearing surface, so periarticular osteolysis is not there, and hence the loosening chances will be less. Contraindications are again infections, non-reconstructable medial or lateral column bone stock, irreparable MCL or concomitant LCL injuries, fracture of the radial head or coronoid that cannot be rigidly fixed. In all these conditions, if any of this is present, then don't consider for distal humeral replacement, but go for a total elbow. So relative contraindications are there, like younger patients, chondral damage or pre-existing osteoarthritis of the greater sigmoid notch or radial head. Anything on the distal side, chondral damages or any fractures and all, again it is a relative contraindication, because ultimately the wear is going to cause pain and poor outcomes. A humeral component which is matched in size and shape to the native ulnar and radial articulation is very essential for the longevity of this procedure. Here you can see that they have fixed the olecranon osteotomy and all. and it is perfectly matching with the ulnar congruence and the radial congruity. Now, lastly, coming to the capitular or the radiocapitular replacement, this is a pretty new thing in which they are only replacing the capitulum, which is not very common when the only seen when the problem is in the capitulum or the radiocapitular joint. So, in the past, capitular interposition with cutis or allograft material for isolated pathology was used. In some instances, an Anconis arthroplasty was performed. But still, if the need is there, you can consider for a replacement. Instances in which capitulum has been involved with primary degenerative arthrosis or trauma with or without involvement of the radial head, when capitular articular restoration is required to control pain or restore mobility. However, if the radial head is normal, there is no reason to replace it. This is the CT image. We can see the radial head is okay here, but there is osteophyte and arthritis of the capitulum. So, this is the ideal case for isolated capitular replacement. Coming to the contraindication, except for the loss of capitular bone stock, the capitulum should not be replaced concurrent with the radial head implant if the host articular surface would appear to possibly tolerate the radial head articulation. This was a case which was fixed for capitulum fracture with ultimately going in avian and was replaced with this capitular prosthesis. This is how the prosthesis looks along with the radial head and bipolar radial head. This was a case which was again radial head fracture was fixed, but 2 years afterwards, they went for a radiocapitular replacement, and again after this the radial head was aseptic loosening was seen within 3 years. So they again replaced the radial head only with cemented radial prosthesis. So thank you.
Thank you, Achin, for such a wonderful overview. Can you just quickly tell us about availability of the implants in India?
Sir,
are there any Indian options available where cost always been a constraint for us? For any of those selective situations, we have to go for it. Major restraint earlier was unavailability of the Indian implants. Even the imported implants were not easily getting available. So what is the scene today?
It is available nowadays in Nagpur. Imported are also there with Evolutis and Indian one with the Biotech, and this radial head is available with RCH and Bombay Ortho. So availability is a problem, but still because of they have number of surgeries being done more nowadays as compared to what was done 15 years ago. So they have made available the sets. But still, I mean, it is not guaranteed you will order and you will get it tomorrow in Akola. Maybe some planning will be required.
Okay. So that was a wonderful talk from your side. So here we come to the end, where I started on a lighter note by showing you that Trump's picture. Let me finish on a little funnier side. Many of my contemporaries, they keep elbowing me by saying most of my vocabularies need dictionary to them to open the dictionary for the meaning. I also thought of finding some phrases about where the elbow is being used, and to my surprise, these Ferengis, they use the elbow word quite often for so many meanings it carries. Two particular phrases caught my fancy, and those were elbow room, meaning something like giving an adequate space or adequate attention, and the elbow greasing, that means something like taking meticulous efforts in performing some activity. So all our participants, I am quite thankful, almost more than 200 participants. At one point there were 300 participants, but till the end, almost more than 200 participants lasted with us for such a protracted way, overshooted by a half an hour almost. But then I'm sure every participant and we the panelists even do realize that elbow injury is one zone where how we need to pay a meticulous attention to for a good outputs or good outcomes out of it, treating those injuries. Once again, I thank all my panelists who graciously helped me in elbowing my way out of this one difficult task that Kale sir had put on my shoulders. I thank you all once again, and I hope that we'll keep rubbing our elbow together hence further as well in the future for taking out some great academics, same like today. Thank you all and good night.
Sanju, thank you very much. On behalf of IMA, I am very much thankful to you, all the speakers, and those who have attended this video conferencing, all the delegates. Sanju, I especially congratulate you for conducting such a nice CME, and I was very much impressed by your presentation, which you have started. Especially the videos and all these things, you have taken a great effort for success of this CME and webinar. Thank you very much and good night.
Thank you, Sanju.
Thank you. I hope all enjoyed.
Yeah.
Anyone got bored?
No.
You are free to elbow me.
It was interesting.
Interesting, yeah.
Congrats Sanjay sir, बहुत बढ़िया, बहुत अच्छे.
Yes.
Well done.
Yes.
Well done.
So that's it, Tejas. We can call it a day. Tejas, you are there?
कौन रे?